All set?
Would you mind leaving your driver's license in the public place?
Your thumbprint, that's an important committee, yeah. The Subcommittee on Health will now come to order. The chair now recognizes herself for 5 minutes. Actually, I'll only use 2 so that we can move things along today. We welcome the Secretary of Health and Human Services, Alex Azar, to testify on the President's fiscal year 2020 budget. Good morning, Mr. Secretary. This is the first time that Secretary Azar is testifying before the Energy and Commerce Committee in the new Congress, and his first stop on the Hill to testify on the President's budget is here. So thank you for starting with us. The President's budget certainly reflects the priorities of the administration. But I believe that our national budget should be a statement of our nation's national values. And I don't believe that the budget does that. The Trump administration has taken a hatchet to every part of the healthcare system, undermining the Affordable Care Act, proposing to fundamentally restructure Medicaid, and slashing Medicare. And this budget proposes to continue that sabotage. In November, the American people rejected the sabotage of health care that took place. And it's the reason that I'm sitting in this chair, and that the ratios of this committee and the Congress has changed. Our subcommittee has worked hard over the past 2 months to examine ways to undo the sabotage of the Affordable Care Act and advance legislation that will bring down health care costs for the American people, and we'll continue that work. And I hope, Secretary Azar, that you will be willing to be a partner in our work to lower health care costs for the American people. And we welcome your testimony and your presence here today. The chair now recognizes Dr. Burgess, the ranking member of the subcommittee, for 5 minutes for his opening statement.
Thank you, Chairwoman, and Mr. Secretary. Good afternoon. Welcome to our humble little subcommittee. It's a pleasure to have you testifying before us today to hear your views about the fiscal year 2020 budget proposal. The President's budget provides Congress with an important blueprint for our appropriations process and with the policies that this President and his administration would like to see in the coming fiscal year. As you know, under the Constitution, no money may be spent from the Treasury unless it is appropriated by Congress, and in a perfect world, no money would be appropriated unless the expenditure has previously been authorized. The Energy and Commerce Committee is a principal authorizing committee of the United States House of Representatives. And I believe this is a critical task, and it's important to get input from the Department of Health and Human Services when we are authorizing or reauthorizing or reforming programs that are under your control. While we do hear from the boots on the ground in our districts, it is the agency that both oversees the implementation of these programs and provides funding to ensure that the organizations can carry out the initiative's goals. Secretary Azar, thus far in your tenure as the Secretary of the Department of Health and Human Services, you have proven to be immensely helpful to this committee and its work. You and your team have been responsive to our requests for information and for input, and you have made yourself available to members so that we can hear about your priorities and your intention to work with Congress on a number of initiatives. I will say this, of all of the Secretaries of Health and Human Services over the years that I've been in Congress, I have found you to be the most transparent and accessible, and I can look forward to continuing to partner with you on your efforts to improve access and quality of health care for Americans. One issue that I have raised in each hearing in this Congress, and one that I hear consistently from constituents back home, is the cost and complexity of the healthcare system. North Texans frequently tell me that they can barely afford their insurance premiums, let alone the costs they must pay to seek the care they need, especially those with high deductible plans. Secretary Azar, I know that addressing the cost of health care and specifically drug prices has been a priority for the department under your leadership. I hope this committee, being the one with the primary jurisdiction over these issues, will work with you as we consider ways to solve these issues. Additionally, as the Energy and Commerce Committee primarily drafted landmark laws, including the 21st Century Cures and last year's opiate effort, the Support for Communities Act, we should conduct responsible oversight to ensure that the Department of Health and Human Services is implementing these laws in alignment with congressional intent. It is encouraging to see that the President's budget request seeks to expand treatment and recovery support for individuals suffering from substance use disorders, in addition to enhancing prevention of addiction in the first place. While it is important to stem the tide of addiction, we cannot ignore those who have a legitimate need for pain treatment, including cancer patients, patients with sickle cell anemia, and others. To that effect, the budget requests $500 million to use for the National Institute of Health to partner with private industry to work towards the development of non-addictive pain therapies, in addition to addiction treatments and overdose reversal technologies. Additionally, I am encouraged to see that the budget proposes a significant sum of money for childhood cancer therapies and significant money to defeat the HIV/AIDS epidemic. Both efforts are worthy of congressional support. Another important agency within Health and Human Services, the Office of Refugee Resettlement, is required to provide care for unaccompanied alien children, a task for which your agency was unprepared when this crisis began in 2012, when President Obama signed an executive order enacting the Deferred Action for Childhood Arrivals. While conditions and quality of care have improved, the number of illegal border crossings continues to increase. And let me be clear, the Office of Refugee Resettlement does not enforce immigration law. They receive children as a result of other agencies' enforcement activities. President Trump's budget includes $3.7 billion in fiscal year 2020 for the Unaccompanied Alien Children Program. Congress charged the Office of Refugee Resettlement with the care of unaccompanied alien children, and I hope this committee will support those dedicated HHS and ORR employees as they continue to work with integrity in the face of baseless allegations. If Congress does not want you to undertake that task, Congress should change the law. It's not up to you,
Gentleman's
it's up to
time
us.
has expired.
I yield back. Thank you.
Thank you. I now would like to recognize the chairman of the full committee, Mr. Pallone, for his opening statement.
Thank you, Madam Chair. Last year, President Trump and congressional Republicans passed a deficit-busting $2 trillion tax cut for the wealthy and corporations. At that time, we all knew who would take the hit when it came time for the administration to produce a budget. And now President Trump proposes a sham of a budget that sticks it to the average working Americans across the board. A budget is a reflection of priorities, and this budget makes clear that ensuring all Americans have access to quality health care is not a priority for this administration. The proposed budget for HHS cuts $1.4 trillion in essential health care programs that are critical to working families and to seniors across the nation. Under President Trump's leadership, HHS has played a major role in policies to sabotage the Affordable Care Act, slash funding for Medicaid, restrict access to women's contraception, and separate families at the border. This is a devastating record for an agency whose mission is to advance the health and well-being of all Americans. The fiscal year 2020 budget continues this sabotage by reviving the failed Graham-Cassidy ACA repeal proposal, which would lead to tens of millions of Americans losing their health insurance and would undermine protections for people with pre-existing conditions. The President's budget also continues the administration's assault on the millions of hardworking families that rely on Medicaid for health insurance, proposing $1.5 trillion in cuts to Medicaid. It also continues the administration's illegal efforts to kick vulnerable Americans off Medicaid through work requirements, lockouts, and red tape. This misguided budget also includes over $500 billion in cuts to Medicare, putting health care for our seniors at risk. These are severe and extreme health care cuts for hardworking middle-class families, seniors, and our most vulnerable. This is a sham of a budget that has absolutely no chance of ever becoming a reality, but it shows the Trump administration's values are not the values of everyday Americans. In addition to explaining the cruel cuts made by this budget, Secretary Azar will need to account for HHS's role in implementing the Trump administration's cruel policy of family separation. This policy has caused so much pain and trauma for thousands of children, and it's clear that children are still wrongly being separated from their parents. And finally, Secretary Azar will also have to answer for HHS's lack of cooperation with this committee's oversight requests. And I stress this, Mr. Secretary. Over the last 2 months, this committee has attempted to work with HHS in good faith in asking for information on a variety of topics, from the Affordable Care Act to the administration's family separation policy. We're requesting important information that is critical to our ability to conduct oversight of the Trump administration. But HHS has been largely unresponsive to our requests, and our patience is wearing thin. If Secretary Azar can't commit to providing us all of the information we've requested, we're prepared to take additional steps to make sure that we get the information that we need to conduct this necessary and long overdue oversight. And I'll get back to that when we get to our questions, Mr. Secretary. But I do want to thank the chair for having this important budget hearing, and thank the Secretary for appearing here today. Unless someone else would like some of my time, I'm going to yield back. All right, I yield back, Madam Chair.
We thank the chairman of the full committee. I now would like to recognize Mr. Walden, the ranking member of the full committee, for his opening statement. Is he here? He's on his way? He's running? I think that we will recognize...
I'll claim the time on behalf of the chairman at this point.
Are you going to...
The chairman,
make
the
his
ranking
opening?
member is on the way, so I'll start out. And first of all, if that's okay with the chairwoman.
Are you making his opening statement? Or
I'm
we
gonna-
can just,
I'm gonna
otherwise
make-
we can just go...
I'm going to make my
Secretary.
statement and then probably yield some of my time to the ranking member. Yes.
You can proceed.
Thank you, Secretary Azar, for being here to discuss the President's budget. I think every member of this committee appreciates what you're doing, and I echo the ranking member of the subcommittee's comments that you've been open and accessible to members of Congress, which is greatly appreciated. And we'll look forward to some of the questioning as we go along. I do think that we'll have some concerns related to certain areas of the budget, including the National Institutes of Health budget as it relates to health care. As you know, I was a health care provider before. I think we'll have a good and solid discussion, I think, about our issues at our southern border. By the way, I've been there, and I believe that the Department of Health and Human Services is doing tremendous work with the situation they've been relegated to address. And hopefully you'll continue to do great work on behalf of all of these people in the area of the humanitarian crisis that is the southern border. And with that, I yield to Mr. Walden, the ranking member of the full committee.
Well, thank you, Doctor. Appreciate it. And to our witness, Mr. Secretary, thanks for being here. Madam Chair, thanks for having this hearing. We want to welcome Secretary Azar back to the committee. Thank you. On a bipartisan basis, this committee has led the way in delivering meaningful health care reforms and policies for the American people. Last year, we worked together to pass into law the Support for Patients and Communities Act. That was the most comprehensive legislation to address a single drug crisis in our nation's history. That bill gave your agency unprecedented resources and tools to stem the tide of the addiction crisis that's still devastating our communities. CDC data tell us there are more than 70,000 overdose deaths in 2017, and overdoses take the lives of more Oregonians than traffic accidents. Whenever we pass a major piece of legislation, I really think it's important to dive back in and do oversight to find out what's working, what projects are still ongoing, and what we need to do better. So I'd love to hear from you today, Mr. Secretary, on the department's work to combat addiction and how we can continue to be partners in getting help to those in need. We also extended and funded a number of important public health programs, including the longest extension of the Children's Health Insurance Program in the history of the program, 10 full years, with record funding for community health centers, which are both important for my Oregon district and elsewhere across the country. I just met with a community health center over the weekend in Klamath Falls. There are 12 community health centers, 63 sites, serving 240,000 Oregonians. It's really, really important work. We also need to continue our work on the cost of health care. I know the administration is looking at the cost of pharmaceutical drugs. From one end of the supply chain to the other, we need to continue that work. So I appreciate your personal interest in moving aggressively to bring down the cost of prescription drugs for patients. Last year, the FDA approved a record number of generic drugs. I would say in part because of the bipartisan legislation we passed here. It brings more competition to the market, drives down prices at the pharmacy counter for consumers. But we have more work to do. And I look forward to continuing this committee's partnership with HHS to rein in excessive costs for health care. I was also encouraged to see a focus in the President's budget on moving toward value-based care. As a country, we must move into a health care system that pays for value and quality of care, but those changes will require major shifts in policy and reimbursement. We must work together on those changes to get them right. The budget also provides new funding dedicated to the President's goal of ending the HIV epidemic. That is certainly a goal I think everyone on this committee can share. So in closing, Mr. Secretary, I appreciate your commitment to appear before our committee today, and I look forward to engaging in a thoughtful and meaningful discussion. If there's anybody else on our side that would like the final minute, be happy to yield. Otherwise, Madam Chair, I'll yield back to you.
You thank the gentleman. I'd like to remind all the members that pursuant to committee rules, all members' written open statements shall be made part of the record. So now, welcome again, Mr. Secretary, and you have 5 minutes to address our not-so-small subcommittee, but very powerful one. Welcome, and you have your 5 minutes to impart your testimony to us.
Thank you very much. Chairman Pallone, Chairwoman Eshoo, Ranking Members Walden and Burgess, thank you for inviting me here to discuss the President's budget for fiscal year 2020. It's an honor to have spent the year since I last appeared before this committee leading the Department of Health and Human Services. The men and women of HHS have delivered remarkable results since then, including record new and generic drug approvals, new affordable health insurance options, and signs that the trend in drug overdose deaths is beginning to flatten and decline. The budget proposes $87.1 billion in FY 2020 discretionary spending for HHS, while moving towards our vision for a healthcare system that puts American patients first. It's important to note that HHS had the largest discretionary budget of any non-defense department in 2018, which means that staying within the caps set by Congress has required difficult choices that I'm sure many will find quite hard to countenance. Today, I want to highlight how the President's budget supports a number of important goals for HHS. First, the budget proposes reforms to help deliver Americans truly patient-centered, affordable health care. The budget would empower states to create personalized health care options that put you, as the American patient, in control and ensure you are treated like a human being, not a number. Flexibilities in the budget would make this possible while promoting fiscal responsibility and maintaining protections for people with pre-existing conditions. Second, the budget strengthens Medicare to help secure our promise to America's seniors. The budget extends the solvency of the Medicare Trust Fund for 8 years, while the program's budget will still grow at a 6.9% annual rate. In 3 major ways, the budget lowers costs for seniors and tackles special interests that are currently taking advantage of the Medicare program. First, we propose changes to discourage hospitals from acquiring smaller practices just to charge Medicare more. Second, we address overpayments to post-acute providers. Third, we will take on drug companies that are profiting off of seniors and Medicare. Through a historic modernization of Medicare Part D, we will lower seniors' out-of-pocket costs and create incentives for lower list prices. We also protect seniors by transferring funding for graduate medical education and uncompensated care from Medicare to the General Treasury Fund, so all taxpayers, not just our seniors, share these costs. I also want to acknowledge the work of this committee on lowering out-of-pocket drug costs. Thanks to legislation on pharmacy gag clauses that this committee sent to President Trump's desk, America's pharmacists can now always work with patients to get them the best deal on their medicines. I believe there are many more areas of common ground on drug pricing where we can work together to pass bipartisan legislation to help the American people. Finally, the budget fully supports HHS's 5-point strategy for the opioid epidemic. better access to prevention, treatment, and recovery services, better targeting the availability of overdose-reversing drugs, better data on the epidemic, better research on pain and addiction, and better pain management practices. The budget provides $4.8 billion towards these efforts, including the $1 billion state opioid response program, which we focused on access to medication-assisted treatment, behavioral support, and recovery services. The budget also invests in other public health priorities, including fighting infectious disease at home and abroad. It proposes $291 million in funding for the first year of President Trump's plan to use the effective treatment and prevention tools we have today to end the HIV epidemic in America by 2030. Finally, I want to highlight an announcement from HHS today. As we commence a process to identify a new Commissioner of Food and Drugs as quickly as possible, I am pleased to announce that the current director of the National Cancer Institute, Dr. Ned Sharpless, will serve as acting Commissioner for Food and Drugs following the conclusion of Commissioner Gottlieb's incredibly successful tenure at some point in early April. NCI's Deputy Director, Dr. Douglas Lowy, will serve as acting director of the Institute while Dr. Sharpless is the acting commissioner. This year's budget will advance American health care. It'll help deliver on promises we've made to the American people. I look forward to working with this committee on our shared priorities in the year ahead, and I look forward to your questions today. Thank you, Madam Chairwoman.
Thank you, Mr. Secretary. We'll now move to member questions, and each member, of course, will have 5 minutes to question the Secretary, and I'll start by recognizing myself for 5 minutes. Mr. Secretary, the budget proposes to cut funding for premium tax credits, which help Americans pay for comprehensive health insurance. But your agency's 1332 waiver guidance supports using federal subsidies to pay for junk insurance plans that don't cover patients when they get sick. The budget also once again revives the failed Graham-Cassidy ACA repeal bill, and the Trump administration has refused to defend, obviously, the ACA in the Texas versus U.S. litigation, urging the court to invalidate the entirety of the ACA's major protections for people with pre-existing conditions. Now, really, I call these items out because they scare the hell out of the American people. These policies have consequences. These words walk into people's lives. So where in the budget, in your budget, are those with pre-existing conditions protected as well or better than they're protected under the ACA?
Well, thank you, Chairwoman, for that question.
Not really, thank you, but...
No, it's a good question to have. It's a good question
You're
to have,
gentlemen.
and we need to have a debate about this because the position of many is that the Affordable Care Act solved all issues for people with pre-existing conditions, and that's simply not the case, as 29 million Americans were priced out of the market with unaffordable care, and those who have access to that care, it may be underinsurance or a card that doesn't really provide it for them.
So will you work with us to strengthen that?
Well, we want to work, actually, that's our proposal. It's a starting point.
On pre-existing conditions.
It's a $1.2 trillion
All right,
grant
we'll
program.
hold you to that. We'll hold you to that. Now, on the actual numbers, 1.4 trillion over 10 years from Medicaid, close to $460 billion from Medicare. How do you reassure the American people that what they count on, what is really necessary in their lives, Medicare beneficiaries, Medicaid beneficiaries, that these numbers, what these numbers are going to do to them?
So on
These are massive cuts.
So on Medicare, we're actually putting it on a sounder footing for the future, and these are provider cuts. Providers aren't going to be happy. Hospitals are not happy. The post-acute providers are not happy, and the drug companies are not happy.
How does that affect the beneficiaries?
It actually reduces their cost sharing because they actually pay a percent often of what we reimburse these providers. So as we end that abuse or minimize that abuse, their sharing goes
Well,
down
why
and we
didn't
save
that, but
taxpayers' money.
why wouldn't providers lessen their coverage to the people that are enrolled with them if you're going to take almost $460 billion out of it?
Well, some of these are
Are we
reforms
going to
that,
depend on the goodness of their hearts?
well, they need to, a lot of them need to be in Medicare. Your hospital's not going to be in existence long if it's not a Medicare provider. What's happening is, for instance, hospitals are gobbling up
Now,
doctors'
what about the
practices
patients?
and jacking up the
Patients,
rates for the
the
same
coverage for Medicare
I don't,
enrollees.
I do not believe any of those three major, which are the major areas of reduction, will impact in any way patient access to services there. I think these are areas like MedPAC.
So you're stating that almost $460 billion, reducing that out of Medicare is not going to affect any beneficiary.
I don't believe it should. In fact, I think it should reduce their out-of-pocket through their cost sharing. These are abuses that
And why,
MedPAC and others.
let me get to, I want to go back to the junk plans. They are receiving federal subsidies. And they're required to disclose to an individual that the plan will not cover their medical bills when they get sick. How does this strengthen coverage for people across the country?
So short-term limited duration plans are meant for people in a transition period. They're not right for everybody, and we actually enhanced the consumer disclosures from what the Obama administration had on them.
We're going to enhance disclosure. I'm all for that. In fact, I offered legislation that would state to people on the cover of the policy, be advised you are not covered for the following. So I think it needs a beware stamp on it. But my time has expired, and I will now recognize. Who am I recognizing now? Chairman, the ranking member of the subcommittee, Dr. Burgess, for 5 minutes.
Thank you for the recognition, Mr. Secretary. Again, thank you for being here today. Let me just, sometimes I feel like I'm trapped in a Charles Dickens novel. It's the best of times, it's the worst of times. So just briefly, can you kind of give us a sense of what it has meant for 2.5 to 5 million people to have been brought back into the workforce and now perhaps have the availability of employer-sponsored insurance?
Well, with the booming economy and with the historic low unemployment rates, we've got individuals who now are not not only having the pride and the long-term sustainability of a job, but have access to health care through their employers. But of course, we have our safety nets. We have our programs like Medicaid. We have, as long as it's on the books, we have the Affordable Care Act and the subsidy program there. But what we're trying to do is expand the reach of available options and affordable insurance and coverage and access to care for the people who were shut out from that marketplace.
And I appreciate what you're trying to do. I actually have a question I'll do for the record on just that issue. This past Sunday night, 60 Minutes, television program that I don't normally watch, aired a special on the research that the National Institute of Health has conducted on sickle cell disease. I worked with patients with sickle cell disease back in my residency at Parkland Hospital. I know what a devastating and painful illness that it is. We heard in this committee 2 Congresses ago how there had not been a new FDA-approved treatment for sickle cell in almost 40 years. In the last Congress, we approved and got signed into law the first major sickle cell legislation, Danny Davis's bill from Illinois, and the president signed it into law. Can you talk just a little bit about what the American people saw on Sunday night as far as the potential treatment for sickle cell?
What an incredible story that was. And I've talked to Francis Collins, our incredible director of the NIH, and I think we all believe we could be within 5 years of an actual cure for sickle cell anemia, an actual cure. And it's using the modern techniques we have of both identifying the defective genes that cause the disease, but then different vectors, whether it's CRISPR or in the case of the sickle cell treatment you saw in 60 Minutes, using a viral vector to actually just change the body's wiring. To see that young girl and the impact it's had on her life, it's a miracle, and we're all so excited about that, and we want to keep doing that across the work of NIH.
Well, again, for somebody who's taken care of sickle patients in crisis. We haven't had much to offer, and this is indeed groundbreaking research, and you and your team are to be commended, and the administration for putting their efforts behind this. So as you know, I have, since the passage of a bill that got rid of the sustainable growth rate formula, we used to fight about that every December. Now we don't, and we are, I believe this committee is still committed to the development of alternative payment models. The physician-led technical advisory panel, or PTAC, I think they had a meeting this week. They have recommended over a dozen models that physicians are just clamoring to join. I understand there's concern over the scalability of some of these models, but can we agree that this is a good sign that APM providers want to participate and want to take place?
Absolutely, and in fact, I know there have been some rough spots in the interactions with the PTAC and HHS, and we've met with leadership and the whole committee. We've shared actually the alignment of our philosophies around where we want to go on value-based transformation. I think we're going to see that the projects that they review will help align there. We've emphasized how important it is that these projects be scalable across the program. So I'm actually quite optimistic about our work with PTAC. It's an incredible group of people on that committee, and we want to make sure we're getting the full advantage of their work and insight.
And would you agree that that was particularly visionary legislation that's passed by this committee?
Absolutely.
Thank you. I knew I could count on you. Well, thanks for your comments about Dr. Gottlieb. Again, what a leader he has been, and I appreciate your sharing with us that the agency is going to remain under capable hands. It is just so critically important. The generic throughput that has occurred under Dr. Gottlieb's leadership is going to make a big difference for patients and their pocketbooks. And your commitment is to continue that?
Oh, absolutely. We're going to be carrying forward Commissioner Gottlieb's vision. Without him, his agenda is my agenda is his agenda.
Very good. Again, we appreciate you being here today. Thank you.
I thank the gentleman. I now would like to recognize the chairman of the full committee, Mr. Pallone, for 5 minutes of questioning.
Thank you, Madam Chair. Mr. Secretary, on June 7th of last year, the administration declined to defend the ACA's protections for pre-existing conditions. In this extraordinary decision, the Department of Justice sided with a group of Republican attorney generals seeking to strike down the ACA and declined to defend the constitutionality of the guaranteed issue and community rating provisions of the ACA. And let me be crystal clear, in declining to defend these protections in the Texas versus U.S. lawsuit, the Trump administration is seeking to once again subject tens of millions of Americans with pre-existing conditions to the discrimination they face before the ACA, and I think it's appalling and indefensible. Now, my questions are about documents, so I just want you to answer these questions, yes or no, about documents. That's what I'm asking, not about policy here. On June 13th, 2018, I sent you a letter regarding the Department of Health and Human Services involvement in the DOJ's decision and requesting documents, communications, and responses to a series of questions. I was trying to find out whether the department had conducted any analysis on the effects of eliminating these protections on costs and access to coverage, particularly for individuals with pre-existing conditions. And I asked about the department's contingency planning if the Trump administration prevails in this Texas lawsuit. Do you, and yes or no, did you receive this letter I'm referring to?
I'm sure we did. I don't recall the letter, but I'm sure we did.
Thank you. On December 7th, 2018, a few months later, I sent you and Administrator Verma a follow-up letter reiterating my request. I requested a complete response to my letter, to my previous letter. Again, yes or no, did you receive this letter to your knowledge?
Again, I'm certain that we did.
Okay. So, Secretary, my staff subsequently reached out to your staff on December 21st, January 2nd, January 11th, January 3rd, February 24th, February 26th, February 28th, March 3rd, March 7th, March 8th, up to now, and yesterday, to check on the status of the department's document production. On each of those occasions, my staff has made clear that this inquiry regarding the department's involvement in the Texas lawsuit is the #1 investigative priority for our committee, for our oversight. And it's been over 9 months, and I still haven't received a response to my letter or a single document. So my question is, has the department even begun a search of your records and the records of others on your staff in response to these letters, which again is, how you responded to whether the DOG's moving forward.
So I apologize for the delay. I do want you to know that I met with our team, I think it was in fact just yesterday, and discussed our compliance with your request there. And I hope they've communicated to Chairwoman DeGette's team. I believe they did yesterday or this morning. We're going to try to get as much of that material over as quickly as possible as we can around contingency planning.
Well, would you commit to providing those documents to this committee by the end of the week?
I don't know about the date on it, but we've already met with we've talked to the staff, I was told, and I was told the staff were happy with the discussion and will be producing that on a rolling basis or reviewing the material.
Well,
but
look, let me explain.
I've told them I want to give you as much as we can.
All right, let me explain. I'm not asking about the CMS records, although, those can be sent as well. I'm asking about your own records. Will you commit to making your records available to search and ensure that the department turns such records responsive over to the committee? I'm not talking about CMS, but correspondence between your own records, if you will, relative to this.
Well, obviously, materials that would involve potential executive privilege would have to be reviewed by interagency and the White House for review of that. But I've told my team I want to get whatever we can that doesn't implicate those types of concerns that we would have to work together on respective and reasonable accommodations. I want to get you materials that we can as quickly as possible.
Well, I just want a commitment to make your records available to ensure that the department turns these documents over to the committee as soon as possible.
We'll commit to be as responsive as we can, but I obviously can't waive various privileges of the president if they're implicated.
Okay. Now, I just have one more question, Madam Chair. I'm just concerned, again, I explained, 9 months, no documents, no response. I just hope that this level of non-cooperation doesn't continue moving forward, with this Congress on these committees' informational requests, because if not, we have to see what additional steps to ensure that the committee actually has legitimate oversight. So, I mean, do you want to just respond? This level of cooperation is really not acceptable. Is this going to continue where we don't get anything or any response for 9 months?
I want you to know I respect your role and this committee's role, and we've beefed up our oversight staffing. We've tried to build the teams, and we'll hope to have a better relationship in the future going forward on any oversight issues.
Right,
we want to have a good, constructive, productive relationship with you and this committee.
Well, I appreciate that, and I hope so, and we'll continue to monitor. Thank you, Madam Chair.
Thank you, Mr. Chairman, and we'll just count on you getting the information to us. I now would like to recognize the ranking member of the full committee, my friend, Mr. Walden.
Thank you, Madam Chair. And again, thanks for holding this important hearing. Secretary Azar, I understand that 2018 marked the highest number of combined generic drug approvals and tentative approvals in the history of the Food and Drug Administration's generic drug program. Can you just briefly speak to the savings that created for the American people?
Well, this is thanks to the historic work of Commissioner Gottlieb and the team at FDA. It's just been incredible. They have shattered monthly and yearly generic drug approval records since 2017, approving generics that CEA has estimated have saved Americans since January of 2017 $26 billion.
$26 billion?
I believe that is only through June of 2018 on that analysis. So that's on a rolling. That's going to keep on adding savings to the American people.
That's really impressive, and I think part of that's the new tools that this committee and this Congress in a bipartisan way gave to your agency and certainly the FDA. And by the way, I would just say I'm really saddened that Dr. Gottlieb is leaving. I wish him Godspeed and good health and every success in the world. He has been a fantastic FDA director, and frankly, Madam Chair, very cooperative, I think, on both sides of the aisle. I think he was up here 4 days in a row once, testifying and participating. Sorry, but it was really helpful to our cause. Mr. Secretary, CMS has proposed a rule to change the formularies for patients in Part D protected classes. What assurances can you provide my constituents and those patients that they'll still be able to get access to the medications they need?
Yeah, thank you for that question, because there's a lot of misunderstanding there. Of course, with the protected classes, what's happening is we have, as a government, disabled these middlemen, the pharmacy benefit managers, from being able to negotiate against the drug companies to get discounts. So for the very drugs that in the commercial space may be yielding 30% average discounts, we're getting 0 to 6%. So what we're proposing, and it's a proposal, and we're getting very important feedback from disease groups and we'll look at that,
right,
is to allow some of the basic formulary management tools used in the commercial space for regular commercial employees. For instance, step therapy, try this drug before that drug, or
Right.
prior authorization, make sure that this drug is actually being used for the right indication with our speedy appeals and exceptions processes, and with the choice that's embedded into Part D where you can pick a plan. If it's not meeting your needs, you can choose a different one. But we're hearing the feedback, and we've heard very vigorous feedback. We want to protect our beneficiaries, of course.
Because I have heard from some patients today, before this becomes a rule on step therapy, that they have a drug that works, they change plans or something happens, and they're told they got to go back through all these drugs they know don't work to get to the one that does, and no patient wants to go through that, and so it's something we got to pay attention to.
I've heard that feedback, and obviously we'll take that very seriously.
Yeah, I think that's really, really important. Mr. Secretary, currently over 1/3 of beneficiaries are choosing a Medicare Advantage plan. And I know how important that is to Medicare beneficiaries, especially my colleague here to the left who has become one now. Can you detail why seniors are increasingly choosing private insurance options for their Medicare coverage?
Well, the Medicare Advantage plans have become so popular. I think it's because so many of us, as we age into Medicare, forgive me,
Right.
that we're used to having an integrated benefit package. We're used to having medical and drug benefits all together rather than those being managed separately. And so it's a very convenient form, and it allows us also with Medicare Advantage, we can add supplemental benefits. The plans, we've actually authorized new supplemental benefits that these MA plans can offer people.
And what would those look like? And quickly.
Oh, that could be lower cost sharing. I mean, you have Medicare Advantage plans, for instance, that have $0 generic drug coverage in them. I mean, some of them just incredible, the opportunities they offer people.
So under H.R. 1384, known as Medicare for All, my understanding is private health insurance would be eliminated, so the 158 million Americans get their health insurance, their employer or union would lose those policies, but also, and something that's not been written much about, my understanding is the Medicare for All Democrats plan would also eliminate Medicare Advantage plans. What would happen to those 20 million seniors?
I believe that is the case under at least that plan. They would lose their Medicare Advantage plan, and they would have to go to what's called Medicare Fee-for-Service, which has very high deductibles, very high cost sharing. Now, for the wealthier people, you can buy in a very expensive Medigap policy to cover some of that. I do not recall if that particular Medicare for All plan outlaws those Medigap plans or not. Being private insurance, it might. I'm not sure.
So seniors would lose their Medicare, their Medicare Advantage plans under that legislation.
I believe that to be the case. There are private plans.
All right. Thank you, Madam Chair. My time's expired. I yield back.
Thank the gentleman, and now would like to recognize a real gentleman, Mr. Butterfield, for 5 minutes.
Thank you. I was about to say, Madam Chair, that Mr. Engel has stepped out for a few minutes, but thank you for
To your advantage.
thank you for the compliment, and thank you, Mr. Secretary, for your testimony here today. I started reading the President's budget very early this morning. It's not a very thick budget as compared to other presidential budgets, but I started reading it this morning, and this is the first section that I went to. It appears to me that the President's budget would rip some $1.4, $1.5 trillion out of Medicaid by turning it into a block grant or a per capita program. And Madam Chair, if that weren't bad enough, the news organizations this morning are reporting that the administration has plans to bypass Congress entirely and issue guidance that will allow states to block grant or cap Medicaid. Now, if you think the emergency declaration executive order that the President announced a few weeks ago to bypass Congress has created a firestorm, you just wait for the firestorm that this will create. 1 in 5 Americans, low-income Americans, depend on Medicaid. The President's budget doesn't represent the values of the American people. And so this Medicaid play was one of the main features of the Republicans' failed attempt to repeal the ACA. Block granting and capping Medicaid would endanger access to care for some of the most vulnerable people in the program, including children with complex medical needs, and our seniors and individuals with disabilities. In September 2017, Avalara Health, a well-known consulting firm, found that the Republican block grant proposal would cut federal spending on Medicaid by $4 trillion over the next 2 decades. Mr. Secretary, Congress has already rejected attempts to block grant Medicaid, so it's deeply troubling to see this administration double down. I will remind you, sir, that under federal law, you only have the authority to allow demonstration projects. You know it, and I know it. You only have the authority to allow demonstration projects that are likely to assist in promoting the objectives of the Medicaid program. And so I'm asking you, sir, on the record today, do you believe, does the administration believe, that you have the authority to block grant Medicaid on your own without the participation of Congress?
So states are able to propose waivers or demonstration projects, as you've described them, to reorient their benefits, and any state could come in requesting, for instance, an approach that might be what you describe as a block grant or capitated amount or different payment structures. If we get that kind of proposal, we'd have to assess that with our legal counsel and with OMB to determine.
It appears you're going to be aggressive with this, aggressive with block granting Medicaid and rolling it out.
Absent statute, we
Yes.
can't force a state to do anything like that in Medicaid. That would have to be a governor and legislature coming to us, asking us if that's something that we
Let me put it to you this way.
flexibility to
Can
do.
you guarantee this committee that capping Medicaid spending through a block grant will not cause any individuals to lose their health coverage or lose their benefits or lose access to their doctors or jeopardize their care? Can you make that commitment to us?
Well, you couldn't make that commitment about any type of waiver or demonstration in Medicaid because that's precisely the types of changes.
So it's
that are made.
conceivable. If a state came and asked for a waiver, that it's conceivable that some of the beneficiaries could experience less care.
That could be the case with any waiver that's already out there. We operate by, my goodness, it must be hundreds of waivers already, and each of those has an impact that's redistributive among this beneficiary or that or this class. It's ways of states prioritizing and focusing the benefits and the money that they
I see
have.
the
So
direction
does
that you're
happen.
going with this, and I don't like it, but you answer to the president, and the president has a notion of taking Medicaid in the wrong direction. The cap of Medicaid that the administration is proposing will only grow at the rate of inflation. That's what I'm being told. Do you believe that the rate of inflation will keep pace with the rising cost of health care? Are they going to go up equally, do you believe?
I think that's in the legislative proposal, which of course Congress would have to agree to. You would have to agree to that. And if that were the case, no, that would be regular CPI, I believe, is in the budget. I don't believe it's at CPI medical expense. And that is part of the savings that come from the ongoing, I think it's 300 and some billion dollars that would be part of the ongoing savings from those types of changes to per capita or block grant options.
Thank you, Mr. Secretary. I only have 14 seconds remaining. I will say as I close that if this administration is serious about block granting or otherwise readjusting and redefining Medicaid as we know it, we're going to be in for a real serious firestorm, not just from the Congress, but from the American people. So many people, low-income folk, depend on Medicaid. Thank you, Madam Chair. You're back.
Thank the gentleman. I now would like to recognize a former chairman of the full committee, Mr. Upton of Michigan.
Well, thank you, Madam Chair, and welcome, Mr. Secretary, back. We're pleased that you're here, and I wonder, as you know and you watch very carefully, as every member of this committee supported 21st Century Cures a couple years ago, could you briefly give us an update as to how you think things are going 3 years now since President Obama signed it into law? Because I have a number of questions, so I know you can.
Let me just be short about it. I believe it is directly attributable and credit to you and this committee for the Cures Act that we have had the record number of new drug approvals and the record number of generic drug approvals in our system that are leading to such significant savings for the system, for the American people, and frankly leading to the type of cures like what I hope we're going to see on sickle cell that the ranking member mentioned before.
That's good, and I missed that show on 60 Minutes, but I'm well aware of the progress that we're making on that and in other fronts as well. Somewhat, I'd say, good news and bad news. It's my understanding that the childhood cancer funds and NCI, you have a nice increase for that in the proposal. But I must say that I was alarmed to read a political story just in the last couple of days. It said, under the plan, the budget plan, White House proposal proposes an $897 million cut to the NCI, plus more than $1 billion to institutes that do medical research. Is that story accurate?
Well, it is. That is in the budget, is the across-the-board reduction to NIH. We're one of the biggest, if not the biggest, non-defense discretionary budgets. We take a 12% cut in the president's budget at HHS. That's $12 billion. It's a proportionate cut at NIH that is proposed. I understand the pain. I understand the concern there. And the NCI cut would be proportionate to the NIH one. I believe it's a 12% there also.
Now, you know, one of the things that we did in Cures was that when we saw increases, particularly in the NIH budget and FDA budget, we actually came up with offsets to make sure that those increases would come about. Are those offsets still in place? I mean, are these reductions?
So we tried to prioritize certain funding with NIH around the opioid funding, of course, the pediatric cancer initiative of the $500 million over 10 package. And so, yes, there are certain priority areas that we've tried to wall off within that, but overall the budget does take that kind of proportional charge because otherwise there's just not enough money at HHS to go around to make that kind of a target.
Now, a number of us from the House and the Senate this last week participated in a pretty big opioid conference. And what is the level of funding as we try to help the states deal with this crisis that is impacting virtually every community and so many families that we personally know?
The president keeps the opioid funding that this Congress has prioritized last year and that we worked together on. We're going to continue to strengthen our access to treatment and recovery. So that's $2.9 billion. That's an increase of 68 above what our FY19 allotment was across the department. That's your state opioid response grants, for instance, of $1.5 billion.
We started that in Cures.
And then the STR, and then expanded it with the state opioid responses in last year's appropriation. $58 million for infectious disease and opioids, a critical part also on our HIV and Hep C work, the spread of those diseases caused through the opioid crisis, prioritizing surveillance activities. So really a continuation of the great bipartisan work of Congress and the administration on the opioid crisis from last year is what's presented in the budget this year. I could give you details offline if that is helpful.
So the last question I have is, last week a letter was sent up to reprogram monies for the Office of Refugee Resettlement. They found offsets for that increase. And I'm interested to know, what is the fiscal year 20 budget request compared to the fiscal year 19 request? And is there a chance then that you'll ask for additional monies to be reprogrammed again following what happened last week for fiscal year 19?
Thank you for that. So in FY19, I believe the budget request was $1 billion plus a $200 million contingency fund. And then the appropriators also put some money into the regular non-UAC refugee program, knowing that usually doesn't spend that much money. For this budget request, what we have requested is actually $1.3 billion as an appropriation, and then to create a $2 billion mandatory fund that's a contingency fund with an assumption of $700 or so million use in this year, plus transfer authority of up to 20%, which would be $361 million. So we've requested quite a lot, but at the rate that we're going with the kids coming across the border, it's just an incredible burden financially.
Thank you. My time has expired. Thank you, Mr. Secretary.
We thank the gentleman. I now have the pleasure of recognizing the gentlewoman from California, Ms. Matsui, for 5 minutes.
Thank you, Madam Chair, and thank you, Mr. Secretary, for appearing before us today. I have to say I'm extremely concerned by the priorities reflected in the President's budget, and because this proposal directly and negatively impacts hardworking families who depend on crucial services. It cuts Medicaid by over $1 trillion. These cuts mean working single mothers in between jobs, families with a family member who suffers from addiction, and grandparents in long-term care facilities will have less access to care. I'm disappointed that HHS, which has a mission to enhance and protect the health and well-being of all Americans, has presented a budget that targets the most vulnerable in our communities: women, children, people with disabilities and mental illness, and the LGBT community. I certainly hope that in our conversation today we can address the failings in HHS's budget vision and how the agency should, in fact, be working to protect all Americans. Now, Mr. Azar, you previously stated that one of your top goals as Secretary is to address the opioids crisis, and this committee shares that goal. Passing H.R. 6, the Support for Patients and Communities Act, was a highlight of last Congress, and I was pleased to see members of this committee and your administration begin to take meaningful steps toward tackling the opioid epidemic. Yet I'm concerned that your proposed budget, while it does include funding and investments for the Community Mental Health Services Block Grant and for certified community behavioral health centers, it is accompanied by massive cuts to Medicaid, which is a vital source of coverage for mental health and substance use disorder treatment. The President's 2020 budget proposes to cut Medicaid by $1.5 trillion over 10 years and turning the vital program into a block grant to the states. Yet, shoring up Medicaid and strengthening that program is perhaps the single best thing we can do to expand access to mental health and substance use treatment services. As I'm sure you know, Medicaid is the single most important financing source of mental health services in this country. Medicaid covers approximately a quarter of all adults with serious mental illness. The Medicaid program covers many inpatient and outpatient mental health services, such as psychiatric treatment, counseling, and prescription medications. And Medicaid coverage of mental health services is often more comprehensive than private insurance coverage. Medicaid also covers 4 in 10 non-elderly adults with opioid addiction, and those with Medicaid coverage are twice as likely as those with private insurance or no insurance to receive substance use treatment. Your rhetoric on mental health and addiction is not matched by your actions. Cutting the very insurance coverage that treats these people for ideological reasons, the coverage that provides critical mental health services and substance use treatment, will not help us address these critical issues. Secretary Azar, do you agree that Medicaid is a critical tool in helping individuals with mental health conditions or substance use disorders? I just want a yes or no.
Yes, we do believe Medicaid is important for those individuals.
Okay. Secretary Azar, will you commit to not taking any further action in this administration, as your predecessor, CMS administrator, already have, that would negatively impact the coverage that people with mental health or substance use disorders rely upon?
Well, we actually, with our budget, are proposing changes that I think refocus us on the key core populations of Medicaid, as opposed to just providing insurance to able-bodied, potentially working adults. So I actually think the budget lets us focus on these people with substance use disorder and mental illness, the disabled, those that really need it, instead of the perverse incentives that we've got right now.
Well, I don't agree with you there. I also believe, too, that it's very difficult to get mental health services, and the population that needs them are certainly ones that don't game the system. They really are people who really need the services. And mental health and substance use services are so critical, and Medicaid is the means by which most of the population receives these services.
If I could just point you to one thing in the budget that I hope you'll support, is we propose extending Medicaid for postpartum pregnant women for up to 1 year who've suffered from substance use disorder. So I do hope we could advance that.
That's really wonderful, but I'm still talking about the vast population that needs the Medicaid services for mental health services. And let me just say this, that I am also, I want to reiterate the concerns of Ranking Member Walden regarding the protected classes. I've gotten many of my constituents coming forward and saying that they are really very concerned regarding the step therapy. They have medication that they already know works, and to think that they have to go back again and go through the steps, that would really bring them back to a place they don't want to be. And I've run out of time already, so I just want to make that point, and thank you.
You yield back. I thank the gentlewoman. I think the issue that Ms. Matsui just mentioned and Mr. Walden, I think both sides hold the same view, so we need to move forward and correct that situation. I now would like to recognize my friend from Illinois, the gentleman from Illinois, Mr. Shimkus.
Thank you,
5
Chairman
minutes.
Eshoo. Secretary Azar, thanks for being here. Chairman Eshoo and I co-sponsored a bill last Congress called the Revamp Act. We have worked to address antibiotic drug resistance for over a decade with colleagues on both sides of the aisle. We have secured some wins, not the least of which is the GAIN Act. Mr. Secretary, can you tell me what your administration is doing to address this concern?
Yeah, so we actually announced what we call the AMR Challenge in September of last year at the United Nations General Assembly, which is a CDC Foundation initiative where we received commitments from, I think, over 100 NGOs and private sector entities to commit around appropriate utilization. And we also, I am focused right now around AMR on what could be, what I view as a potential market failure issue there on antimicrobial resistance, developing next generation antibiotics, because here's the problem we have. We want new antibiotics, but for AMR purposes, we need them not to be used. So that it almost presents a Project BioShield-like scenario where we, as the government, need to actually think about our role there as a purchaser to get developed and park antibiotics that are needed.
Yeah,
key issue.
I appreciate the way you finished up that, because we've always said quite a bit is how do you incentivize the private sector to produce a product that you hope they don't use? And that's kind of what we've been trying to deal with here. I wasn't here for Dr. Burgess's questioning, but he talked about alternative payment methods. Big fan of Medicare Advantage plans. I understand the move on some discussions in some areas about Medicare for All, but how can using alternative payment methods affect quality and cost in this in the Medicare Advantage world?
So I actually think we've been often thinking about things the wrong way when we think about, for instance, the Center for Medicare's and Medicaid Innovation and our demonstration authorities. We tend to think of fee-for-service, the traditional Medicare, as where we need to innovate, and then Medicare Advantage would just follow. Well, the competitive structures with Medicare Advantage and their customer responsiveness, and frankly, their ability to run plans, these are insurance companies, what they do. They know how to run insurance and integrated benefits and deliver outcomes that are quality outcomes. I've been trying to change our mentality to think about MA as more of the leading edge of innovation, and perhaps fee-for-service is a fast follower there.
Yeah, let me follow up with that. What about waivers to the Stark and anti-kickback statutes? You see that addressing in that space might be helpful?
Yeah, so we actually have, it's called the Regulatory Sprint, which is an effort that our Deputy Secretary has been leading, looking at how the anti-kickback statute interpretations and Stark laws could be barriers to integration, collaboration, and coordination, because to get the kind of outcomes we want to pay for value, we have to stop paying just each individual provider in a procedure-based rifle shot and pay together and have them work together, but we have laws that say don't work together. So we have to look at it. We have to protect against fraud. We have to protect against abuse, but we've got to open up and make sure we allow that collaboration outside of common ownership structures.
Well, thank you. When we knew about the hearing, we opened up to our social media for people to maybe direct a question or two to you. And Melody Tucker from Charleston, she actually submitted a whole bunch, like 30 of them. So I'm going to go through them all. We don't have time to do that. But one of the questions she had was, will salary, I'm just going to read it the way she sent it. Will salaries of healthcare providers, including physicians and professional/paraprofessionals staff, be determined by the government? And she is in the reference to the Medicare for All debate. Would you see that as, she goes on with saying, if so, how is Medicare for All not socialized medicine? I mean,
well, I think there's a real risk with Medicare for All that it become, depending on the plan, that it become a single-payer system. And if it's a single-payer system, one eventually may want, the move may be to actually own the providers that are under that, as we see with other countries' socialist systems around healthcare. And so, yes, that would end up with a system where Congress or HHS would set salaries for providers. I hope we don't ever get to that point, but I do think that's a risk with single-payer systems. We've seen it in other countries.
I appreciate that, Madam Chairman. My time's expired. I'll just yield back.
To thank the gentleman, I now have the pleasure of recognizing the gentlewoman from Florida, Ms. Castor.
Thank you, Madam Chair, and thank you, Secretary Azar, for appearing before us today on the Trump budget. After reviewing the Trump budget, I know my neighbors back home in Florida would want me to ask you, why does the administration continue to undermine the law that protects them from discrimination by insurance companies for pre-existing conditions? And they would want me to ask you, why does the administration continue to saddle families with higher health care costs, co-payments, and premiums? And let's get into the specifics here. Your department finalized a rule to expand short-term limited duration health plans. These junk plans are not required to comply with the comprehensive consumer protections of the Affordable Care Act. Junk plans undermine protections for people with pre-existing conditions. They increase cost. They leave American families with fewer financial protections and expose them to fraud. So yes or no, are you aware and did you consider in rulemaking that these junk plans discriminate against Americans with pre-existing conditions?
The short-term limited duration plans do not have to comply with the Affordable Care Act's 4 requirements, and we need to make sure people understand
so I'll take that as you were aware?
Some plans may, and I believe are covering pre-existing conditions, some are not, and that needs to be fully disclosed.
Are you aware that, so you are aware that these plans can exclude coverage for pre-existing conditions or decline to offer coverage to individuals with pre-existing conditions? Yes or no?
That is correct. That is correct. And that's why people need to be fully aware of that if they go into buying them.
No, I think what should happen is that we should adhere to the law of the land, that we do not allow discrimination against our neighbors with pre-existing health conditions. That's what the law says.
If that were the law of the land, then President Obama violated it during his entire presidency.
Secretary Azar, yes or no? Are you aware and did you consider in rulemaking that these junk plans exclude coverage for basic health care services such as hospitalization, treatment for substance use disorders, or prescription drugs? Yes or no?
Short-term limited duration plans may exclude coverage. That's exactly why they can be more affordable options for some people.
So the department also concluded that expanding junk plans will, and I quote, increase premiums and cause an increase in the number of individuals who are uninsured. Other nonpartisan estimates, including the CBO, have also projected that expanding junk plans will increase premiums. So yes or no, are you aware and did you consider in rulemaking that expanding junk plans will lead to higher premiums in the individual market?
Did consider that. The CMS actuary had some analysis around that, but given that we now pay for the insurance for everybody in the individual market, we're subsidizing, I think, over 87% of people's premium acquisition. Nobody should be leaving subsidized insurance to buy one of these plans. If we're buying you a full insurance package, I don't know why you would leave and buy a short-term limited duration plan out of your own pocket.
Well,
doesn't make any sense to me, but.
Let me say, the CBO was very clear on this. Yep. They projected premiums will increase by at least 3% due to your junk plan rule. And other studies, including one out of the Urban Institute, they've projected higher premium increases across the board as well. You're going in the wrong direction.
Well,
families need relief. And what is happening is your sabotage, allowing these junk plans, is hurting everybody. And we had expert testimony last week from folks that are implementing in many states that said as much. Your department also finalized a proposal in the final rule that would allow junk plans to be renewed for up to 36 months. This was not presented in the proposed rules, and the proposed rule and stakeholders did not have an opportunity to provide input in rulemaking. Why did HHS sidestep the rulemaking process and finalize a major policy change that was not presented in the proposed rule?
I don't believe we did, and my memory is that we asked the question whether there was legal authority for renewability, but I'm not confident of that. But I thought we had asked that question, but I'm not aware of any legal infirmity in the administrative process.
So you're saying the department's general counsel provided a legal opinion on the renewability provision?
No, I'm saying that I thought we had asked for comment in the notice of proposed rulemaking around the question of renewability. I may be mistaken.
Would you
My
please
memory is-
share those documents with the committee?
No, I'm saying we asked the question to the public as to whether, and asked for comment. You were asking about whether something was fairly included
Yes,
in the
could you
notice of
provide
proposed rulemaking.
those documents that you said you provided to the public and any of the legal opinions or
Well, it would be in the Federal
questions?
Register because it would be, what I'm saying is I think in the notice of proposed rulemaking, we asked that question. I
Are you
may be
saying
mistaken.
you would not provide those
I don't
documents?
think you're listening to what I'm saying, which is that it's in the notice, I believe in the notice of proposed rulemaking, we ask the question and
But
then
your
would
department's
get feedback.
general counsel's legal opinion would not be in the Federal Register. Would you please provide those documents to the committee?
We would have to review that under a request for privilege and decide and determine whether that's appropriate to share.
I don't believe that you did.
Gentlewoman's time has expired. I now would like to recognize the gentleman from Kentucky, Mr. Guthrie.
Thank you. Thank you, Mr. Secretary. Just a couple of things before I get to my questions. I believe short-term duration plans were legal under the previous administration.
That's correct. For the entirety of the Obama administration, they existed for 12 months up until just the waning hours of the Obama administration when they cut them back only to 3 months to try to drive people into the exchange market.
All right, thanks. I want to also, we talked about per capita caps, and I worked on this in the previous Congress. And I remember having a letter, and it was entered in the record when we had a hearing, but that each member, Democrat member of the Senate who had been serving at the time, who was still serving, who was serving in the 1990s, I think it was 96, signed a letter for per capita allotments through Medicaid and Medicaid, I'm sorry. And former committee chairman Henry Waxman in a 1996 congressional hearing said that federal government would maintain its commitment to sharing the cost of providing basic health care and long-term coverage to vulnerable Americans. And he correctly pointed out that states would have both the incentives and the tools to manage Medicaid more efficiently. He did say that obviously the federal assistance would have to change if there was increases beyond the control of states, hurricanes, floods, outbreaks of contagious diseases. But that was something that in the 90s at least was more bipartisan. Let me just get to, I had a lady came into my office the other day, and a lot of us have people that come regularly with different groups with diseases, and she was ovarian cancer, and touched my heart. But her biggest struggle when I was talking to her was about her daughter. She had her grandchildren because her daughter had an opioid addiction. Everything she was going through, that was really on her heart and mind, and we talked about the opioid bill that we passed. I know that's supported in this budget, and I particularly had an area called Comprehensive Opioid Recovery Centers Act, which to give comprehensive coverage. It became Section 7121 of H.R. 6. And could you talk about that specific section, if you have that information, and the implementation of it moving forward, or just the overall implementation of H.R. 6 as well?
I'm afraid I'd be happy to get back to you. I'm afraid I don't have details on that particular aspect of the implementation. We're obviously thankful to you and this committee and Congress for the SUPPORT Act and the tools that it provided us on the opioid epidemic. Nearly every part of HHS is involved in implementing the SUPPORT Act. It is such a comprehensive piece of legislation. We're driving forward under the direction of our Assistant Secretary for Health, Admiral Brett Giroir, and trying to make sure we meet all deadlines in implementing all the various provisions of the Act.
Thank you very much. And also, I want to just kind of ask you this. The House Republicans strongly believe that it's important that we ensure protections for individuals with pre-existing conditions. And this is a commitment by you and President Trump, correct?
That's correct. The President has made clear he will sign no legislation that would change the Affordable Care Act that does not protect pre-existing conditions. His budget mandates that if Congress were to pass it, the $1.2 trillion American Health Care Grant Program to states would have to have effective risk pooling mechanisms or other genuine protections for pre-existing conditions, which we've actually worked with states to do. I have granted, I believe, 7 waivers to states under the Affordable Care Act to create reinsurance pools that have actually brought premiums down from 9 to 30% as a result of these pre-existing conditions pooling mechanisms.
Thank you. And also, under the Obama administration, premiums in the individual market increased every year, but President Trump has enacted several deregulatory reforms and premiums have decreased. Is this true?
That's absolutely true. Premiums for the first time in the history of the Affordable Care Act actually went down almost 2% from 2018 to 2019, and we saw the first increase in the number of plans since 2015. These are directly attributable to steps that we have taken to try to stabilize the marketplace, including the first thing that we did on it was a marketplace stabilization rule that were the things the insurance industry said we need to be able to run a predictable, actuarially valid, non-gamed system. So we've been going out of our way to try to protect it, to make the premiums lower and choices better.
Okay, thank you. There's been proposals for Medicare for All, a single payer government-run Medicare for All bill. 158 million Americans receive their insurance through their employer or their unions. What would happen to these 158 million employees if we pass Medicare for All, from the proposals you've seen?
So CMS's data is actually 174 million Americans have their insurance through their employers, and under the plans, at least some that I have seen, your employer insurance would immediately go away because it would be outlawed. You would have to go on Medicare. Even plans that don't mandate that immediately would eventually cause the private sector plans to go away because you would create such a financial advantage for the Medicare plans, which I think pay 40% less to providers by law, end up paying 40% less than commercial plans. It would effectively drive all private plans out of business. So one way or the other, the different iterations would lead to 174 million Americans not having the insurance they have today.
Thank you. My time has expired. I yield back. Thank you.
I thank the gentleman. I now have the pleasure of recognizing the gentleman from New York, Mr. Engel.
Thank you, Madam Chair, and thank you, Mr. Secretary, for being here today. 15 months ago, the Republican tax scam bill passed and was signed into law, and I said at the time, and it's even more true today, the impact of that legislation has led to exploding deficits and therefore also has led to the President's budget calling for a 12% decrease in the HHS budget. This budget continues to promote the long-sought goal of dismantling the Affordable Care Act by another failed attempt at so-called repeal and replace the law, and weakens protections for people with pre-existing conditions. This would leave millions of Americans without meaningful health insurance. Over 10 years, this budget calls for a $1.5 trillion cut in Medicaid and a $500 billion cut in Medicare, partially offset by inadequate investments in health plans which bypass consumer protections. The cut in Medicaid is approximately $1 in $4 spent today, resulting in millions of Americans losing their coverage. The budget does provide a very modest $291 million towards the President's call for halting the spread of HIV. As Chairman of the House Foreign Affairs Committee, I'm particularly opposed to cuts in funding for global AIDS programs. There's a 22% cut in PEPFAR used to treat millions internationally, mostly in Africa, a program started by President George W. Bush. There's also a proposal to water down the U.S. contribution in the Global Fund to fight AIDS, TB, and malaria from $1.35 to $1.1 billion. Inexplicitly, we also see budget slashes to the CDC of nearly 10%. Funding for the NIH takes a 12% cut of $4.5 billion, with the National Cancer Institute absorbing most of that hit. Can you imagine that? So, Mr. Secretary, this HHH budget is completely unacceptable and is a direct threat to the health and well-being of all Americans. I have a couple of questions. I'd like to ask you, Mr. Secretary, yes or no, can you guarantee that cutting almost $26 billion from hospitals that serve low-income and uninsured individuals will not result in a reduction in services, endanger access to vulnerable populations, or contribute to hospital closures?
I'm not sure which particular cut to hospitals you're referring to in $26 billion. If it's the Medicare changes on hospitals gaming the system by jacking up private practice rates when they buy a physician practice.
Dish payments is what I'm referring to. Under this formula, some of the largest dish cuts will be on states that chose, like mine, that chose to expand Medicaid, while states that rejected Medicaid expansion will get much smaller cuts. So with the additional dish cuts you're proposing, continue this policy of punishing states that expanded Medicaid with steeper hospital cuts?
Correct me if I'm wrong, but I thought the point of the Medicaid expansion actually was tied to dish payments going down. That was part of the funding mechanism in it. I may be mistaken, but I think that's actually part of the original, what President Obama and the Congress enacted, and we're sort of carrying through on that,
but how do
believe.
how do the cuts in the CDC and NIH budgets promote life-saving research for those Americans desperate for a cure?
Those are the cuts at CDC and NIH are a challenge, and it's a starting point. With a tough budget environment, these are difficult choices. We've tried to prioritize, and I understand you or others will disagree with those choices, and we're happy to engage in an ongoing discussion. It's a starting point for that.
The choice I'm really against is the choice that gives tax breaks to very wealthy people in exchange for what we're seeing right now in this budget, hurting the poor and the middle class and their ability to have adequate health care. You have hospitals in my district and all surrounding districts that serve a high number of Medicaid patients, and the uninsured are a critical part of our health care infrastructure, and they ensure that our most vulnerable citizens have access to the care they need when they need it most. And these hospitals rely on funding, I know you know this, through the Medicaid Disproportionate Share Hospital, or DSH, to help keep their doors open and their lights on. And Medicaid DSH payments help support hospitals across the country in all types of communities, urban and rural. And at the end of this year, hospitals will face substantial cuts to their DSH funds if Congress doesn't act. So the President's budget, the way I look at it, doesn't propose to reduce or delay these cuts. Instead, it doubles down and proposes increasing the size of these cuts over a longer period of time. And by your own projections, this would result in $25.9 billion in cuts to Medicaid DSH on top of the $44 billion in DSH allotment reductions under current law. I don't see how hospitals will be able to sustain cuts of that size. Could you please explain to me how that would be possible?
Again, I believe that's inherent in the Affordable Care Act structure, and in terms of uncompensated care, I thought that the Medicaid expansion and the Affordable Care Act were supposed to get rid of the uncompensated care. So, I mean, we can't keep the old system and have the new system on top of it and keep paying the same amount of money. That's at least our perspective in the budget.
But let me just say, Madam Chair, and then I'll end. To me, it doesn't matter as long as we're not pulling away help that people need now. It seems to me that from these cuts, there's no way that you can call it any other thing, but we're taking money away, and many, many more people will be left uninsured and will have no help. And to me, that's not the way we should be going, providing tax cuts for the wealthy in exchange for everybody else getting screwed.
We thank the gentleman. I now have the pleasure of recognizing the gentleman from Virginia, Mr. Griffith. 5 minutes questioning.
Mr. Secretary, in trying to answer some of the questions just a minute or two ago, you were talking about the DSH payments and some of the bigger hospitals buying up small satellites in order to be able to get DSH payments they wouldn't otherwise be qualified for. Did you want to expand on that?
I'm afraid on the DSH payment issues, I'd have to get back to you on that. If you have a question on that on detail, I'd be very happy to have us get back to you there.
In regard to having socialized medicine and have it, the same parameters as the current Medicare system, where you referenced that the medical folks are paid 40% less under Medicare. Have you all done any studies on how many healthcare providers would leave the field? And let me tell you why I asked that question. My mother is 88 years old. Obviously, she's been on Medicare for a while. Recently, her primary care physician retired. She started making phone calls and made a couple of calls and found that the doctors that she called were not taking any new Medicare patients because of the reduced payments that they were going to get. And she just decided she'd work with her older doctors who were the specialists that dealt with the areas of concern instead of having a primary care physician. So she's actually getting less care now than she got before. And it made me think that perhaps at a 40% reduction, a fair number of healthcare providers, particularly those who might have other means of supporting themselves, might just go do something else. Have you all done any studies on that?
I'm not aware of any studies that have been conducted yet. I think that's a fruitful area for inquiry. We ought to look at that. We certainly see that with European socialist systems, though, that you get the better providers or hospitals will often opt out of the socialist system because of underpayment. And what you get is a two-tier system. You'll have basically an essential medicines, essential services system, and then you'll have others who can buy up in a private sector system to alternative providers and hospitals in there. That's not to say that these are bad healthcare systems, but it is a two-tier system.
And with our current system, where a lot of people get it through their employer, it doesn't matter whether you're the CEO or the guy working the line or the lady working the line, you get the same system. And now we're headed towards a system that might actually have two tiers, where the people with the money can get that specialist, but the people who are working on the factory floor
may not be able to get that specialist. Is that correct, yes or no?
I'm extremely concerned about a two-tier system like that.
And so that's a yes.
That's a yes.
That's
I
what I
believe
thought.
ERISA protects everybody.
My time is slipping away from me. Just let me say this as you all look at things. We've got to figure out a way to do reimbursements for telemedicine across the board because telemedicine can save us money in the long term and provide better care in rural districts like mine, and I'm a big proponent. Any way I can help you with that, I would greatly appreciate it. Also, you all have been looking at DIR fees, the direct and indirect payments to pharmacists. It seems to me it's an inequitable situation that we have now where, you know, months later, a pharmacist who has sold a drug, and I have lots of these across my rural district community pharmacies. They're not big companies. They're little, small mom and pop operations. And they get noticed that, you know, they owe tens of thousands of dollars 6 months after they've already filled the prescription. You can't go back to the patient and say, oh, by the way, I told you it was a $20 drug. It turns out it was a $30 drug. You just can't do that, and the pharmacists are having to eat that. Y'all are working on that, and I appreciate that. You all, last year in a Senate hearing, you stated you were going to direct your agency's Office of Inspector General to conduct a study on these DIR fees and how these fees specifically impact community pharmacists. Has that study been completed, and if so, when do you expect to release the results?
I believe it is well underway, and I hope it'll come out quite soon.
All right, I appreciate that. Also want to talk about durable medical equipment, prosthetics, or orthotics and supplies, et cetera. Competitive bidding program's been put on hold. Appreciate that. One of the concerns in a rural area is that, you know, you may only have one or two suppliers, and while the equipment might be available to somebody if they drive down the mountain in 45 minutes to an hour, but sometimes these folks aren't capable of doing that, and we're squeezing out the folks who would actually take the equipment to them. In that regard, the agency now has plans to include non-invasive ventilators in the durable medical equipment program. Those obviously assist people that can't breathe on their own. Can you explain the rationale and clinical criteria used in the decision to include non-invasive ventilators in the next round of bidding?
Sure. The Social Security Act gives us authority to phase in items that begin with the highest cost and highest volume items or services, and those items that we determine have the largest savings potential. And so all of the items that we've selected for competitive bidding are high-cost, high-volume items with very large savings potential. We've got a comprehensive monitoring program, and it's shown that beneficiary access and health status outcomes have been preserved under the program. We've been very concerned about the impact in rural. That's why we made the modifications that we did, I believe, mid-year last year, and then carrying forward to attempt to ensure fair reimbursement and fair competition for rural areas especially.
I appreciate it, and yield back, Madam Chair.
Thank the gentleman. I now have the pleasure of recognizing the gentleman from Maryland, Mr. Sarbanes, for 5 minutes of questioning.
Thank you, Madam Chair. Thank you, Secretary Azar, for being here. Just wanted to make sure the record was clear on a couple things in response to Congresswoman Castor's questions with regard to the junk plans. I just want to point out that while with respect to the renewability question of these plans, it does look like the department went through the normal course in terms of the NPR and allowing public comment there with respect to the extension of these plans to 36 months. That did not come until the final rule was proposed, and in that sense, it sidestepped the kind of transparency that I think we have a right to expect. So that's the first thing. The second thing I wanted to note is you've been asked a number of times about the cuts to NIH. And you really don't have a good answer for that because I think it's indefensible. And there's going to be a lot of continued inquiry in that regard because we want to stay on the cutting edge in terms of researching and finding cures to these life-threatening diseases that afflict so many Americans across the country. But I wanted to talk specifically about the opioid crisis and address the impact of the pharmaceutical manufacturer marketing efforts with respect to the crisis. On February 26, a Washington Post article titled, "Inside the House of OxyContin," detailed the actions of Purdue Pharmaceuticals and their owners, the Sackler family, in marketing opioids as safe and effective to the medical community. It highlighted, the article did, that Purdue pioneered direct-to-physician marketing and used this approach to lead a marketing strategy to persuade providers that opioids were both safe and effective for long-term use, despite a lot of scientific evidence to the contrary. One member of the Sackler family was quoted from an email in 1996 saying, quote, "This strategy has outperformed our expectations, market research, and fondest dreams," end quote. 20 years later, we're dealing with the consequences of this marketing strategy. And I don't need to remind my colleagues that opioid deaths hit a record high in 2017 with 70,000 recorded opioid deaths that year. So, how is HHS going to hold pharmaceutical manufacturers accountable for drug marketing strategies that are boosting profits while harming our communities? Could you speak to that, please?
Well, Congressman, thank you for raising it. It's really important because you're right. That is a big part of how we got into this opioid crisis, were the practices in getting legal opioids out there and getting them out in primary care and getting them extensively overprescribed. I think we write five times, I think, the European average in terms of legal opioids. We've been aggressively working on that. We've actually gotten legal opioid prescribing down 22%, and on a morphine molecular equivalent down 27% so far since January of 2017. The President has directed, and the Justice Department has been working, and we will support fully the Justice Department in going after any manufacturers who engaged in illegal or unethical conduct. DOJ joined in the litigation by the states against these manufacturers, and that process is ongoing. But certainly we will take that it will take any cases anywhere the evidence goes. Share your concern, deeply disturbed, and we see the foundation of this crisis in the legal opioid use that started, I think, back in the 90s.
Well, I do think we need to step back and systematically look at what these marketing strategies are and decide whether we're going to lean against them going forward. What's the standard of scientific evidence at HHS and FDA in terms of what's required from pharmaceutical manufacturers when approving drug applications, especially in the case of opioids?
New drug applications, and I'd want to defer to my colleagues at FDA because, I will say my current belief, but please, I'll ask my colleagues and we'll correct it if I get it wrong. Usually, for an on-label indication, you would require 2 double-blind controlled studies, randomized clinical trials, to support a labeled indication, and then for other information that you would provide about the drug, I believe it is a substantial evidence test, but I'm
worried that whatever the standards are that are being applied are not achieving the goals that the public would want to see in terms of kind of rigorous decisions about what's safe and what's not safe. And you may have heard that the former FDA Commissioner, David Kessler, is concerned that opioids are being used in a way that was never proven to be safe or effective, particularly the decision on FDA's part to expand the label use of opioids to allow long-term use, which is something that probably should not have happened. So as I close, I just want to say that I think HHS and FDA have to put a plan in place for retroactively reviewing the safety and efficacy of existing opioid projects. Let's go look at what's happening right now, because it could be continuing to fuel this opioid crisis. So it's not just a retrospective here. This is about making decisions going forward that can help us get out of this crisis. With that, I yield back my time.
Thank you.
Thank the gentleman. I now would like to recognize the gentleman from Florida, Mr. Bilirakis.
Thank you, Madam Chair. I appreciate it so very much. And welcome, Mr. Secretary. Appreciate it. I want to talk about Medicare Part D. When Congress created Medicare Part D, it did so with the belief that private sector organizations, which are already administering employer-sponsored drug benefits, could be used to administer a Medicare drug benefit. We now have Medicare Part D, where drug plans compete against each other to provide the lowest price to beneficiaries. It's probably the only federal program that consistently comes in under budget with premiums that have remained largely unchanged. And I know this has been going on for years. It's a very successful program. In my district, excuse me, in my district, we have 191,000 seniors, and about 80% of them are on either Medicare Part D or they participate in a Medicare Advantage program with a drug benefit. Some people have talked about changing Part D and having the government negotiate drug prices. Do you think the government can negotiate a better deal than what the plans have been able to negotiate over the past 15 years? Again, we want what's best for our constituents. We want low drug prices, and I know you do too, and the president as well. So that's the question. Again, do you think the government can negotiate a better deal than what the plans have been able to negotiate over the past 15 years?
I do not believe that we could do a better job negotiating than these pharmacy benefit managers do, absent creating a highly restrictive, uniform formulary for every senior citizen in America. And that's what Peter Ortzag, the head of the Congressional Budget Office and President Obama's OMB director, concluded also. These PBMs have significant market power. They negotiate discounts where we let them that are comparable to European OECD levels of discounting, is my understanding and experience. But we would have to create a single formulary. We would have to say to every senior, you may have this drug, but you may not have this drug. I mean, we've heard the bipartisan concern even today on step therapy and utilization management within protected classes. Imagine the outcry if we were to say to all seniors, you may have, and I'll just pick a drug, you may have Humira, you may not have Enbrel. That's the only way I could get better savings than the PBMs are able to negotiate. And I think a lot of the concerns would be here. I'm not sure a lot of folks who ask us for that negotiation understand the implications from a beneficiary choice and access perspective. I'm happy to have that discussion with both sides of the aisle on this, because we want to solve the drug pricing crisis. We want to solve that, but we want to solve it in the right way with patients at the center.
Thank you very much, Mr. Secretary. Again, yeah, you're right. I mean, your heart's in the right place. The president's heart is in the right place. Everyone. We want lower drug prices, but again, we also, choice and accessibility are so very important for our seniors. I assume that you've reviewed the Medicare for All proposal.
I have seen and heard about different iterations of it, sir.
Yeah. So how would the Medicare for All proposal affect the successful Medicare Part D program, in your opinion?
It would take it away, because Medicare Part D is a private plan administered program with private insurance, is my understanding, at least of some of the versions of that.
Yeah, and you know, in my opinion, it's not perfect, and we're going to close the donut hole. But it's been a very successful program. I hear from my seniors all the time. How would Medicare Advantage, Medicare Advantage is very popular in my district. 53% of our seniors are on Medicare Advantage. They really love the program. How would Medicare for All affect the Medicare Advantage program?
I believe Medicare for All, under at least some versions of the Medicare for All program, that Medicare Advantage would disappear because it is a private insurance program administered by the government, but I believe it would go away and all would go on to a Medicare fee-for-service, the old-style 1960s Medicare that people are increasingly not choosing because they want the more private sector, flexible, choiceful benefit package of Medicare Advantage.
Well, thank you very much. It'd be a real shame if we lost that. Take care.
So.
Thank you very much, Mr. I yield back.
To thank the gentleman, I now would like to recognize the gentleman from Oregon, a wonderful member of this committee, Mr. Schroeder.
Thank you very much. Appreciate it, Madam. Thank you for being here today, Mr. Secretary. Appreciate it very much. Not particularly a big fan of the budget that's rolled out for HHS, to be honest. We're a big fan of the ACA. This would repeal it, and Medicaid program gets cut, cuts to research, those types of things. But I try and look at the silver linings here, and the prescription drug cost suggestions merit, I think, some good look-sees. In particular, you know, generics are saving us $250 billion a year. It's a big area. I prefer, like my good colleague from Florida, market-based solutions in terms of how we encourage competition is probably the best way to go about that. And there's, in the generic space, we currently give manufacturers 180 days exclusivity when they file for a new generic drug, but there have been some problems with that exclusivity. Sometimes they just don't get around to marketing the drug, in a timely manner, and that exclusivity drags out well beyond 180 days, basically blocking others from getting into the marketplace and further reducing costs for the consumer. So a couple questions, if I may. One is, how often does a first filer block competition from subsequent generic manufacturers, and how long does that parking actually seem to last? Any examples recently?
So my understanding is that on average, we see about 5 of those instances a year where you'll have that first to file essentially squat on their 180-day exclusivity. And on average, that leads to about a 12-month delay in generics coming to market. So it is a very significant access and financial issue.
All right. Any recent examples of that?
I don't have a particular company or product in mind. We could try to get that to you, but those are the average numbers there.
All right. Well, that'd be great to get that information, some real-life examples. And what's the motivation, basically? What's the advantage for these manufacturers to, park their exclusivity? It would seem sort of obvious, but what have you seen?
Well, there could be instances where they simply can't make the drug. There are often manufacturing problems, so somebody gets approved, but they're not able to bring it across the finish line and manufacture. But there may also be instances where there's a deal between the generic company and the branded manufacturer to forestall the starting of that 180-day clock so that the branded company can keep selling the branded drugs.
I see.
It is a likely potential source of great abuse on access to generic medicines for our people.
Yeah, and I think the goal would be hopefully to provide opportunity for folks to get into the market as soon as possible. Maybe some changes can be made so that a second, generic that comes to market in a timely manner would start triggering a clock.
And the president's budget has that proposal in there, and I appreciate your leadership and Congressman Carter's leadership supporting reform here that would fix this real abuse of our generic system.
Last question is, some people argue that the forfeiture of that exclusivity that's currently in statute provides enough protections against the parking issue that we're talking about here. I understand there have been some problems, frankly, enforcing that forfeiture portion.
Yeah, I think the evidence would be to the contrary, that in fact we're seeing this as a real problem and getting rid of that abuse by having the clock start as soon as the drug is available from an approval perspective. And if they don't launch, as soon as there's a second drug available to come on, that clock should start, or other different solutions. So the forfeiture provisions that are there are obviously not quite sufficient. We need to fix this 180-day clock issue.
Very good, very good. Well, I appreciate your interest in that issue, and hopefully it's one of many areas we can work together on. Thank you very much, and I yield back, Madam Chair.
I thank the gentleman, and we are going to have a legislative hearing tomorrow on the very issue that you just raised with the Secretary, and I hope that we have good bipartisan support on addressing that abuse. I now would like to recognize the gentleman from Indiana, Mr. Bouchon. Dr.
Thank you, and welcome, Secretary Azar, to our subcommittee. I do agree with one of my colleagues on the other side that my constituents do need relief, but it's from the high deductibles and premiums created by the ACA and the following years after that. Secretary Azar, I was pleased to see that the administration's focus on the 340B program again this year in the budget, specifically a call to require transparency regarding the use of program savings by 340B entities. This goes hand in hand with the important work done by this committee, the Energy and Commerce Committee, last Congress, and the Oversight Subcommittee, in highlighting the need for 340B reform, and also in exploring specific legislative proposals aimed at strengthening the program. I was proud to sponsor a bill last Congress that would introduce common sense data collection for 340B entities previously facing no oversight. It is very concerning to me that a significant number of hospitals in the 340B program may be providing low levels of charity care despite the rapid growth in the program recently, mostly through the acquisition of child sites, and face no requirements to report on their use of 340B savings. First question I would have, would you support including a charity care requirement as a condition of eligibility for the program?
I'd have to look at that and see what the administration position would be there. In our budget, of course, we do propose that to get the benefit of savings from our reimbursement change.
Correct.
that you would have to provide, I believe, at least 1% charity
1%.
care. So to be a beneficiary of the budget neutrality from the outpatient changes, you'd have to do that. So we at least are partway there already in our proposal.
Okay. Do you think that we should have a minimum charity care level met across all hospital networks at the main hospital, but also within their network?
Well, it's certainly the
complicated
rationale on
question.
The rationale on 340B is that you're providing that type of care, and so it's something we need to be looking at. Happy to work with you on that.
Appreciate that. And based on your budget, would you agree that HRSA needs more authority to create clear and enforceable standards for the 340B program?
Absolutely. We need regulatory authority, we need oversight authority, we need transparency in 340B, and we need a user fee program so that those benefiting from 340B pay for the oversight that we need to provide over their use of the program.
Thank you for that answer. And could you also agree that we need to require all 340B covered entities to report savings achieved from the 340B program and their uses?
I think that type of transparency could be very useful. It's not obviously a formal statement of administration position, but we're generally in favor of that type of transparency.
Understand. Thank you again for addressing 340B in your budget, and I yield back. The gentleman will yield to the ranking member. Yes, I will.
I thank the gentleman for yielding, and this is such an important topic, and of course this committee, the Subcommittee of Oversight and Investigations, did do a significant amount of body of work and produced a report last Congress that I encourage people to look at. But Mr. Secretary, there was something that occurred along the way in the 340B genesis that got us to this point, and that was the ability of a contract pharmacy to participate in the 340B program. Do you have any thoughts as to whether or not that is adding to our difficulties?
It is adding to the difficulties and the issues around integrity of the program and just original purpose, and I do think it would be great if this committee could look into this question. You know, it was a well-meaning idea at the start, which was if a hospital doesn't want to run its own pharmacy for low-income patients when they come in, let somebody else run it. Okay, that made perfect sense. But then it became, well, what if they need something a little closer to home? So extend the contract pharmacy out to pharmacies maybe in the neighborhood of the patients of that hospital. It's now become an industry. It's become an industry of contract pharmacy, of basically shared profit between the pharmacies and these hospitals. It's worth looking at to see the extent to which it's fulfilling the original purpose and what Congress really intends 340B to be about. I leave that to you all, but I do think it's worthy of being on your agenda.
Yes, and I completely agree, and to the extent that mergers and acquisitions might involve one of those 340B contract pharmacies, it's worthy of our discussion. So I thank the gentleman for yielding. I'll yield back to you.
I yield back.
Thank the gentleman. I now have the pleasure of recognizing the gentleman from New Mexico, Mr. Lujan.
Thank you very much, Madam Chair. Secretary Azar, yes or no, were you given advance warning of the Department of Justice's decision to not defend the law?
I'm sorry, you're speaking, I assume, about the Texas litigation? I just want to be sure. You said
Yes, Mr.
the
Secretary.
law. I just want to make sure the law we're talking
Mr.
about is the
Secretary.
Affordable Care Act.
Yes, Mr. Secretary.
Yes, I knew the filing that was going to happen on behalf of the United States.
How were you notified of the Department of Justice decision? Did you receive a phone call, an email, or a written letter?
Our department is involved in consultations regarding the filing of litigation in which the department has interest or is a party, and so we have communications with the Justice Department.
You had a phone call, or was it an in-person meeting? Was it a letter? Was it a note?
The nature of the discussions that I have regarding deliberations on filing of the position of the United States in litigation in this case are not ones that I can have full discussion about.
You can't say, I understand that you've already refused to share those documents, but you can't say if it was a phone conversation or an in-person meeting?
Our department has discussions with the Justice Department and other officials regarding the position in highly significant cases of litigation of the position of the United States. And yes, I had
Mr. Secretary, did you personally have those conversations?
I did indeed.
Look, it's simple. If the district court ruling stays, millions of Americans would lose their health coverage, health care costs would skyrocket, and life-saving health care would become unaffordable for American families. Secretary Azar, yes or no, did your department conduct an analysis to evaluate the effects of the Department of Justice's position on consumer costs and coverage?
I don't know if we did at the time, and as I spoke with Chairman Pallone earlier, we're working to gather up if we do have analytics around impacts of the court decision in the case. We're working to provide those to the committee.
Can you commit to providing that then to the committee? That's something you will do.
I asked my team to find any materials like that and provide those to the committee, that type of analytics, and to provide those to the committee absent some problem. I think they've communicated with committee staff to that regard. Absent something I'm not aware of, I want to make sure you get that information.
So, Mr. Secretary, surrounding the initial questions that I asked as well, why is it that there's a reluctance to share that information with the committee?
To share the analytics,
Not the analytics, Mr. Secretary. Why is it that there's a reluctance from you to share the information pursuant to the conversation surrounding the Department of Justice's decision to not defend the law in the Texas case?
Well, obviously, discussions of individuals, cabinet members at a certain level regarding positions of the United States in litigation are historically, over the course of the history of this country, highly privileged, sensitive discussions, especially with pending litigation.
Well, Mr. Secretary, I think that there's a decision that was clearly made associated with positions of the administration. The question that I have and why I'm asking the questions that I am is in your Senate confirmation hearings, you repeatedly stated that you were committed to enforcing and upholding the Affordable Care Act. Is that correct?
I absolutely am. As long as it is the law of the land, I will, in my administrative authorities, work to make it work for the American people, in my judgment, as best I can.
Well,
but that's not a statement of whether something's constitutional
Mr.
or
Secretary, if I may, the administration has made an unprecedented decision to throw away the responsibility to defend the Affordable Care Act in law.
So I want to be very clear. Our policy position as an administration and mine is to protect pre-existing conditions. You're speaking about a legal piece of litigation the Justice Department leads on. We want pre-existing conditions protected. Our budget actually has a concept about how we can do that with a replacement of the Affordable Care Act. Happy to work with this Congress on alternative ways and approaches. The President has made it very clear he will never sign any new legislation replacing the ACA that he does not believe does protect people who have pre-existing
Mr. Secretary, I'm glad that you brought attention to the fact of the policy related to people with pre-existing conditions, because you and I very well know that the Trump administration has specifically disavowed ACA provisions that guarantee coverage and protect people with pre-existing conditions. I think that that's ignoring what has occurred. Your testimony today seems to be ignoring positions that have been taken by this administration that you yourself said you would uphold.
Offering, I think you're probably referring to short-term limited duration.
No. I know what I'm referring to, Mr. Secretary, and I think that it's critically important that we understand what's occurring here today and what's not occurring. And I certainly hope that you'll reverse your refusal to share documents with this committee. And with that, Madam Chair, I yield back.
I thank the gentleman. We have 3 votes on the floor, so the subcommittee will stand in recess until immediately after votes. We still have several members that are in line to question. I have 14 members. There are 3 that have waved on, but that's still a large group. So, Mr. Secretary, it's a chance for you to take a stretch, relax for a few minutes, figure out how you might answer the questions that are to come, and we will return as soon as votes are completed. Thank you. waiting for you. Call the subcommittee back to order. Thank you, Mr. Secretary, for your patience, and we'll move on with questions. It's a huge pleasure because she's been such a wonderful partner in so many things. The gentlewoman from Indiana, Ms. Brooks, for 5 minutes of question.
Thank you, Madam Chairwoman. And Secretary Azar, we have talked about this in the past, the Pandemic All Hazard Preparedness Act, a program that while we have reauthorized it once again in this Congress, and I really want to thank the Chairwoman, Congresswoman Eshoo, who worked with me both last Congress and this Congress to get this across the finish line here in the House once again. It's not yet been reauthorized. We have not yet been able to get it through the Senate. It's supported by a host of public health groups, the Alliance for Biosecurity, and when we kicked off the Congressional Biodefense Caucus together, you participated and spoke at that Biodefense Caucus, and I thank you for speaking about the importance of PAPA. During your remarks, you mentioned that you were involved in the writing in 2002 of the Bioterrorism Act. And I want to commend you because it appears that in the Public Health Social Services Emergency Fund, there is, for the most part, either level funding or some increased funding relative to pandemic all hazard preparedness. But can you share with us the negative impact of PAPA not being authorized? And if we cannot get this through the Senate, there are several programs that actually expired in 2018. I won't go into those, but what does this do for our private partners in the very critical public-private partnership in the medical countermeasure enterprise?
Well, thank you, Congresswoman Brooks, for your support of PAPA and for your advocacy on the bioterrorism front. We are committed to reauthorization of PAPA. We're committed to protecting Americans, and reauthorization of PAPA is an important part of that. There are several expired provisions that HHS does need to be able to continue the important work in this area. There's a FOIA exemption, there's an antitrust exemption, there's a National Advisory Committee on Children in Disasters, and there's a provision for temporary reassignment of federally funded personnel. And the expiration of these provisions does endanger our security and the broader medical countermeasures development enterprise that we have. You know, these medical countermeasures are dependent upon a very unique and fragile U.S. government-industry partnership in this cradle-to-grave enterprise. Specifically, if a pandemic were to occur, BARDA, which is our research and development agency, would currently be unable to negotiate and bring together certain critical medical countermeasures manufacturers due to a lack of antitrust exemptions. That's just one example of how we're at risk right now.
And I think because it's not, commonly understood, that's because BARDA does sit with different manufacturers of vaccines to have a discussion. Is that correct?
Exactly. We can convene competitors under the antitrust exemption, and they can speak freely in ways that they otherwise wouldn't be able to.
And that provision has expired?
That has expired.
Okay, so right now they cannot convene that type of meeting if we were to have an unusual or a pandemic and have those discussions.
If we had a pandemic and needed to scale up production immediately for a pandemic flu vaccine right now, we would not be able to engage in those collaborative private-public partnership discussions across industry.
Okay, thank you. And would you, with respect to the funding, I certainly see that the National Disaster Medical System has actually been plussed up from 57 million in the FY19 to 77 million. If I'm not mistaken, that is bringing in medical providers from around the country to help us in cases of disaster, of which we've seen quite a bit. Is there anything you'd like to say about that? And then we also went down, though, a bit on hospital preparedness program by 7 million.
Right. So the National Disaster Medical System is a bedrock of our preparedness and response program. So these are individuals who have day jobs, doctors, emergency medical technicians, veterinarians even, who work with us and allow us to surge in. For instance, you will see these people when you're at various events like the State of the Union. A lot of the medical professionals that are here are actually NDMS members here to protect you and me when we're here for national security events like that. And so it's a vitally important program, and I'm very glad that we have a proposal to continue the investment with that.
Can you talk very briefly about the other provision that expired and the National Advisory Committee on Children and Disasters?
This is, of course, just getting advice from the best advisors out there on how we can focus on children in disasters. There are very unique needs and threats for children in a disaster situation, trauma, mental health, then we want to get the best advice possible, and PAPA enables that.
Well, thank you. We look forward to working with you to help us get that over the finish line in the Senate. Thank you. I yield back.
Thank the gentlewoman. It's a pleasure to recognize the gentleman from Massachusetts, Mr. Kennedy, for 5 minutes of questioning.
Thank you, Madam Chair. Mr. Secretary, thanks for being here. Thanks for your patience as we went over to vote. Last fall, Mr. Secretary, it was reported that your agency was considering establishing a legal definition of sex under Title IX. According to the New York Times, the memo would narrowly define gender as a biological condition determined at birth, and any dispute about one's sex would have to be clarified using genetic testing. Mr. Secretary, is that memo real?
So there was litigation, I think it was at the end of the Obama administration, and a federal court actually enjoined enforcement of, I think this is the section 1557, is that the provisions you're talking about?
Yeah, but does the memo exist? The New York Times said this memo exists.
I'm not going to comment on whether some preliminary memo exists. We're working on complying with the court's order to come up with just how do we implement. The court said the Obama administration's regulation was invalid, and we'll just work to faithfully implement that across relevant agencies.
Can you give us a copy of that memo? Can you give us a copy of that memo then?
We'll certainly look at that. I don't know it's an internal memo, if it's appropriate to disclose.
Potentially going to impact millions of Americans into not disclosing that, or at least hundreds of thousands.
I wouldn't necessarily assume that's operative continued thinking that whatever was in any previous document.
So moving on, sir, do you believe that health care is a right for all Americans in this country?
I believe that we have an important duty, all of us, this committee and this administration, to make health care as affordable as possible for all Americans.
So in less than a year, nearly 20,000 low-income people in Arkansas, sir, have lost their health care because of a work requirement that your agency approved. At the same time, the unemployment rate in Arkansas has barely budged. Is that a successful policy implementation?
So at the request of the Arkansas government, we did approve a community engagement waiver program with them. The individuals who've fallen off that program, we do not yet have data as to why they fell off the program.
Have we asked them? Have you asked them?
Yes, we're working with them. That's part of the data gathering. That's part of the learning process.
And when do you expect to have that data back?
I don't know if it's timely for that. It's quite new. It's quite new in its implementation. So tracing the data out to see did individuals, as you said, advance into work with a employer insurance and hence not qualify for Medicaid anymore, need Medicaid anymore? We just don't know at this point.
Well, Mr. Secretary, so in your agency's budget, you propose implementing mandatory work requirements for Medicaid beneficiaries, not knowing what the impact will be across every single state. And according to some estimates, upwards of 4 million Americans can lose access to health care, 83% of whom would only lose coverage because of onerous reporting requirements. You just said you're not sure why people are losing it, yet you've now said that you want to extend that to every single state. What's the logic in that?
The logic behind that is we believe that it's a fundamental aspect for able-bodied adults, and if you are receiving free health care from the taxpayer, it's not too much to ask that you engage in some form of community activity, engagement, work training. That's consistent with TANF and the important welfare reforms that were bipartisan. The administration's budget proposal would actually harmonize these across all public welfare programs.
Your mission is to try to make sure that everybody gets access to health care in this country. Can you point me to one study that says that work requirements make people healthier? One.
We believe that individuals who have employment have healthier outcomes. I don't have the data to cite. We've used that in the litigation.
You run an agency responsible for health care for millions of Americans. Healthier people working does not mean that work requirements make people healthier. I assume you understand that.
Well, we're dealing with it because of the Obama.
Is that true, yes or no?
Could you repeat the question?
Healthier people working is not the same thing as work making people healthier. Is there any single study you can point to, yes or no, that shows that work requirements make people healthier?
I'd have to provide that in writing to you if we have that.
I look forward to the answer. Thank you. You are aware of studies in Ohio and Michigan that showed that Medicaid expansion actually helped beneficiaries obtain jobs or remain employed. Are you aware of that? studies?
Medicaid can be a hand up for individuals to help them with transitioning into work. The goal of all of these programs should be to help people become independent, and that is all of our goal.
Except the data that you're looking at seems to indicate that there's tens of thousands of people that are losing health care at a policy that you want to extend across the country without answering why.
Well, we don't know if they lost if they fell out and stopped complying with the work or community engagement requirements because they actually secured jobs and just didn't need to.
And does
complying.
cutting Medicare and Medicaid by $1.5 trillion actually make this program easier to extend health care to more people?
So what we want to do is we want to remove the Medicaid expansion for able-bodied adults.
The budget indicates,
focus
Mr.
the program
Secretary,
on the age-blind disabled.
Yes or no, you're cutting these programs by $1.5 trillion.
Our proposal does have a $1.4, I believe, trillion cut over 10 years to Medicaid, yes.
And so I would imagine that cutting a program by $1.4 trillion does not actually make the program strengthen the integrity of the program or make it easier for people to gain access to insurance. I would like to finally conclude with the basis for my comments on this, which is it is the perspective of at least this member of Congress and I think other colleagues of mine that Medicaid work requirements are against the Social Security, the very statute that incorporates Medicaid, Section 115 of the Social Security Act, and are illegal. Yield back.
Gentlemen, I thank the gentleman. Now I'd like to recognize the gentleman from Oklahoma, Mr. Mullen. 5 minutes of questioning.
Thank you so much. Let me go back to the work requirements for just a little bit. Social Security is something that people paid into because they work and it's deducted out of their paycheck, and it's something they've earned. It's not an entitlement. It's something that they were required to pay into, and so it's supposed to be there. If I'm not mistaken, the work requirement only targets individuals that are able-bodied individuals, means there's no disability, there's not a reason why they can't work. It's able-bodied individuals that are single with no dependents. Isn't that correct?
Able-bodied individuals, I don't know about the single, they would need to be able-bodied and you wouldn't have pregnant women, and I believe we've, with all of our waivers, have ensured that there's an exclusion of, for instance, women who have young children.
Right, with no dependents. Right.
Tried to be very sensible about it.
When in the proposal that I looked at was able-bodied individuals with no dependencies.
I need to check if that's in the budget. That's certainly the theme of what we've approved with waivers, has been ensuring that's very common sense individuals who there's no issue why they couldn't go do volunteer work or job training.
And one of the things you were saying is you don't have the data because a lot of these able-bodied individuals, they were able to go get jobs, and we have employer health care that could be covering them. There's no statistics out there to say one way or the next, but if they dropped off, they probably went and get a job, just like my employees. Since I've had my very first employee back in '97, I provided health care for them. There's no need for them to be on there at that point. Is that correct?
Right. If the program has enabled, if the booming economy, the historic low unemployment rate, and this program has enabled individuals to secure jobs where they get employer insurance, they don't need to be on Medicaid anymore. That seems to be a win for taxpayers and a win for them, a win all around.
Sure. I mean, listen, we got 7.3 million plus job openings right now. We're all competing. All employers, like myself, we're competing for that employee, and benefits sometimes is what puts it over the top. So I commend you for giving Arkansas and other states the ability to run their state as they see fit, because we got to put more people in the workforce. Otherwise, we're just going to be holding our economy back. So thank you so much for doing that and explaining it. Let me turn my attention right now to 42 CFR Part 2. Are you familiar with that, sir?
I am, yes.
Well, as you know, last year we worked pretty tirelessly here in the House, had hearings on it. We were able to get it out of this committee to the floor. It passed overwhelmingly with bipartisan support, 357 to 57. And unfortunately, it goes to the Senate and dies, which so many great things do. And so we are now facing with the real possibility that we're costing people's lives at this point. We have doctors that aren't able to really see the full patient's history. And we understand that HHS may be working on some rules that could help soften this a little bit. Is that correct?
We've been very public about the fact that we've heard the concerns from you, from patients, from family members about
Physicians?
Physicians, law enforcement, just around the care for people with serious mental illness and substance use disorder, and are they getting what they need, or are regulations artificially standing in the way while still trying to protect their privacy needs? So yes, we're working on proposals where we might try reform there, and also, of course, we appreciate the work of Congress in looking to reconcile Part 2 with HIPAA's requirements, and thank you for your leadership and work on this issue.
It's vitally important. I think it's hit home to most people around the country right now, especially with the drug abuse that's taking place and the amount of opioids that are out there on the streets. So I appreciate it. Is there anything that we can help you with that HHS might be considering with 42 or CFR Part 2?
I'd say certainly continuing Congress's efforts to look at reconciling Part 2 to HIPAA to make sure that we have uniform standards. There's just so much confusion out there. That's one of the things that I hear a lot is there's, with these privacy provisions, they're important privacy provisions, but you get a lot of over-lawyering at hospitals and schools and otherwise that basically tell people, no, you can't do this, no, you can't do that. We try to correct it with FAQs, but as you said, people's lives are actually at risk. If parents don't know their kid is suffering from an opioid addiction, that's a problem. If a patient goes back into the hospital and they don't, and the providers don't know they're a recovering opioid addict, and they give them opioids and put them back on it in a procedure, that's a problem.
Right. I couldn't agree with you more. I don't have time to get to my IHS questions, but I do want to work with you in getting some of the recommendations that has been recommended for IHS. It's in disarray, especially with what just came to light with the physician that pediatrician has been abusing their patients for over 25 years, and there was a lot of missteps and opportunities to get them out. So we'd love to work with you and maybe see if we can implement just some standard SOPs through IHS and help monitorize that system.
Look forward to that. Thank you.
So thank you so much for your time.
Thanks, gentlemen. I would now like to recognize with pleasure the gentleman from California, Mr. Cardenas. 5 minutes of questions.
Thank you, Secretary Azar. Welcome to the People's House. And thank you for coming today for the opportunity to ask questions, and more importantly, to finally receive some of the answers in full view of the American public. There are certainly many topics to select today, but I want to spend some time focusing on an administrative policy that shocked the nation in the not-so-distant past, the policy of separating children from their families. Just recently, Secretary Nielsen testified before Congress on this same policy, but I'm particularly interested to hear from you, Secretary Azar, considering your position leading the agency whose mission statement, as you said in your opening statement today, to enhance and protect the health and well-being of all Americans by providing for effective health and human services by fostering sound, sustained advances in sciences, underlying medicine, public health, and social services. That being the case, I'm interested to hear what, if anything, was done to protect these children and what is being done to address these ill effects on the children and their physical and mental condition. So my first question is, in cases where a parent is separated from a child because of criminal conduct or safety-related concerns, what evidentiary standard is required to justify the separation, and what written guidance or policy, if any, is provided to your department by DHS personnel making these determinations and when it comes to the child's welfare and expertise that comes out of your department?
So we do not separate children.
Correct, but then
right, the decision to separate would be made over generally at DHS, and that would usually be CBP, sometimes ICE over there. I do know there are standards in the TVPRA, the Trafficking Victims Protection Act, that certain felonies require prior felony conviction is required there, but I'd have to defer to DHS on what the contours are. We don't actually have a say in what the standards are necessarily that they would use. We get children, and hopefully we get with as much information as possible why they're coming to us either across the border or coming from a family unit.
Reclaiming my time, what I'm trying to get at here is HHS is better qualified with expertise to deal with children, especially when they're separated from their family. DHS doesn't do that as well as you do they turn them over to you. Is that correct?
That is correct,
Okay,
yes.
so the root of my question is this. That having been the case and thousands of children having been turned over to HHS from DHS, is HHS engaged in advising DHS so that they can make better decisions in the interest of the physical and mental health and well-being of that child?
So I think that's a very fair question. I don't think we're fully engaged in the sense that they have their agents who have to make judgment calls on individual cases. They have their standards internally. I don't have those. I would obviously welcome the opportunity for HHS's child welfare professionals to provide advice and assistance to DHS in making those calls and setting standards for their SOPs. We may have done so. I apologize. I don't. If it's happening, I don't want to slight the process, but we'd be very happy always to be engaged in that.
If HHS has been engaged in dialoguing with DHS on these matters, if you could forward any of that to us so we can understand the collaboration that's going on, so that hopefully, should these separations ever continue, and it's my understanding that some children are still separated from their parents, that we would at least expect that in the United States of America, with all the resources and expertise we have, they would be minimizing the effects on these children's physical and mental well-being, adverse effects on their well-being. So if there's any information showing that that dialogue is going on, to me that's good. We'd love to know what that is.
Yeah, thank you. It's a very important question and concern. I appreciate your doing that.
Okay, and also, has HHS already instituted policies, protocols, and procedures to limit harm to children and their families during these separations? In other words, since these separations have become so public and the numbers have grown most recently, has HHS changed or instituted new policies? Because we're in a paradigm shift right now with the numbers being higher than they've probably ever been before in American history.
So we've dramatically improved the information sharing practices, the IT systems between the departments, so that we can track and make sure that we always have it very easy to keep the kids connected to the parent. We want to make sure they're in touch all the time, okay? All of our children are separated in one form or another. They all are under mental health evaluation, and within 24 hours, they all get mental health evaluations, and I think we continue to learn how to deal with the particular traumas and mental health issues associated with being away from one's parents, whether back in Guatemala or in ICE custody. And so I think we continue to try to be a learning organization and improve the quality of care for these kids while we're entrusted with them.
My time's expired. Thank you, Madam Chair.
Thank the gentleman. Now it's a pleasure to recognize the gentleman from North Carolina, Mr. Hudson.
Thank you, Chair. Mr. Secretary, thank you for being here today. It's almost 3.5 hours now because of our vote, but I really appreciate you making yourself available for so much time. Your leadership at HHS has been exemplary. And in general, I really appreciate the efforts you're making on behalf of the American people to make health care more accessible and more affordable. I want to put that on the record in case my questions today make it appear as I only have concerns. But the first being that on February 15th, I sent a letter with 22 of my colleagues, 3 of which are here today, to Commissioner Gottlieb in regards to recent proposals by the FDA on menthol cigarettes and e-cigarette sales in convenience stores. It was reported on March 1st that Commissioner Gottlieb presented his plan to the White House, yet the FDA has still not responded to serious concerns raised by my colleagues and I about this proposal. Will you commit to getting FDA's response back to our letter, back on our letter before HHS moves forward with this proposal?
We have different elements in what was publicly discussed by the commissioner regarding both e-cigarettes, and then there was a separate issue of menthol additives. I'm sorry you haven't had a response yet from Commissioner Gottlieb on that. I don't want to delay any process that may be underway, though, to take action, especially on this issue of the e-cigarette epidemic that we have. This is it's a real public health crisis with the access and the attractiveness to our teenagers and even middle school kids. And so I don't want to do anything that might delay that process. It really is, we're very, very concerned about this e-cigarette issue and what's happening to our kids.
Well, sure, and even if you share the goal of wanting to keep these out of the hands of kids, I think it's still important for us to understand the process and what kind of rules you're proposing, so we'd appreciate a response.
And anything we do in this space would be subject, of course, to whether it's rulemaking or good guidance practices, would be a public process with comment and feedback to make sure we're striking the right measure. We We have to make sure with e-cigarettes, they can be a very important public health tool for getting adults who are addicted to combustible tobacco off of that. It's better to be on nicotine, an alternative nicotine delivery product, than to be on combustible tobacco. But at the same time, we can't allow it to become an on-ramp to nicotine addiction or eventually combustible tobacco use by our middle school kids and teenagers, and just the utilization is soaring through the roof of those products there. So that balance, we'll get feedback on that, and we'll get input on that, on how to strike that right balance, because it needs a balance.
I agree with that, and I think the industry, for the most part, except for some bad actors out there, and also a concern about shipments from China of illegal product and counterfeit product. I think those are all things we need to work on. I think we can agree to work on together. But I think the data shows this is a safe alternative. And so far the process is flowing one way, where we're seeing people come off combustible tobacco to the vapor type products, and we're not seeing the reverse as the case. And so I do think it's a public health improvement, and would appreciate being in the loop as much as we can as you move forward and look at that. The second issue I saw in the budget proposal, the HHS is proposing that FDA begin collecting user fees from the e-cigarette industry to support regulation of their products. In general, I think FDA has demonstrated how beneficial user fees can be, especially in the drug and device space, to provide much needed resources that an agency responsible for regulating one-fifth of every dollar spent by Americans. In the tobacco space, however, FDA has not had the same relationship. The Tobacco Control Act has been a law for a decade, yet FDA has approved 0 products through the modified risk tobacco product pathway. Is it your intention that these new resources through a user fee would begin a new period of approval at FDA?
Yes, that's the purpose of extending the user fees to the e-cigarettes as alternative tobacco products, would be to provide us the resources, enable us to build out the regulatory architecture and approval processes for these products, which we've executed regulatory forbearance on to date.
Right. I appreciate that. Last issue, changing course a little bit. The President's pledge of the State of the Union to eliminate new HIV infections by 2030 is a far-reaching and important goal for U.S. public health. The financial resources proposed in yesterday's budget release speaks to the President's commitment to improving diagnosis, testing, and linkage to care for HIV. I commend the President for taking such a monumental effort and hope to do what I can to support his plan. Given this goal, though, I must ask about a problem a number of my constituents that are HIV patients have raised with me. Medicare Part D provides for protected classes, where Medicare must generally cover all drugs within that class. With HIV drugs being one of the current 6 classes, I'm running out of time here, but my basic question is, how does HHS intend on balancing the goal of introducing cost control measures such as prior authorization and step therapy with elimination of new HIV infections by maintaining patient adherence to working drug regimens in the HIV space?
Happy to get back to you in writing on that, for the chairwoman, if that's okay.
Sorry about that. Important issue, but I appreciate the response.
It's a very important issue. Thank you.
Thanks.
I was expecting a long answer from the secretary. He said, well, to get back to you. I thank the gentleman for his questions, and now I have the pleasure of recognizing the gentleman from Vermont, high-value member of this committee, Mr. Welch.
Thank you very much. Secretary Azar, thank you so much for being here. You know, there's 2 things about health care. One is access related to cost, and the other is cost. And on the efforts there's 2 ways to bring down the overall cost of health care: restrict access or lower cost. And I'm opposed to cutting access, but I'm determined to work with you on your efforts to lower cost. And I want to say something. I believe that President Trump on prescription drug prices is intent on bringing down the cost. I believe you are. I thank you for your meeting. I believe you're committed to doing that. I know Chairwoman Eshoo is, and I believe Ranking Member Burgess and our ranking member of the entire committee who's here, Mr. Upton, is. So we have got a chance. And a couple of things. You've got some good things in the budget. It calls for a statutory demonstration authority for up to 5 state Medicaid programs to test a closed formulary, and we can address that later. It proposes to authorize you to leverage Medicare Part D plans negotiating power for certain drugs covered under Part B, so I support those. And the proposals you've made in the budget also, they're outside of the They're in the budget, yeah, about opposing delay tactics, where I think some of my colleagues, like Mr. Carter, who's got a lot of experience in this, are totally supportive. My goal is for us to do those things, ideally do them together, because I think that'll increase our prospects of success in the Senate, and a bipartisan approach on that would really be helpful. So I do have a couple of questions just to see your position on a few other things. You do support, as I understand it, ending pay for delay. Is that the case?
We do. In fact, our budget has a unique pay for delay provision in it that if you do a pay for delay agreement, you would actually be penalized in the Medicare Part B system.
And that's really good. And you want to curb the REMS abuses.
Absolutely do. So the CREATES Act and working with you on that.
Right. And the product hopping that has been occurring is another way. Are you opposed to that as well?
I want to make sure I'm understanding.
It's the abuse of citizens, it's
the
product
citizen
hopping,
petition
the
issues,
citizen
yes. We want to crack, yes.
and other forms of evergreening.
Yes,
I mean, that's just manipulating the
We want to
market.
crack down on any forms of manipulation or evergreening of patents and exclusivity beyond what the original deals were.
All right, and the president also indicated that he wants to require the drug companies to disclose the price of the products they're advertising, something Jan Schakowsky and our committee is championing. Right. Now, on this question of negotiation, you know, you raised earlier, what is the dilemma? If you want to get real savings, you need a strict formulary, and that restricts patient choice. But if you have no formula, the cost is so high, it restricts patient access. And the way we approach this in Vermont is we did have a formulary created by physicians and pharmacists like Mr. Carter, but there was a fail-safe so that if the doctor said, Peter, you just need the other drug, that would get me outside of the formulary. Are you open to exploring some ways to try to address, I think, the shared concern about not having a formulary restrict appropriate access, but to get the benefits of lower cost that would spread out across the system for all of us?
So I agree with you that the simple fact is if you don't have a formulary and the ability for someone, the middleman, the pharmacy benefit manager, to control and move share, they can't jam pharmaceutical companies for discounts and rebates. They need power. They've got to be able to move. That's what our proposals in Part D and Medicare Advantage have been about, is how do we create power against the pharma companies to get discounts? But with the competition of D and MA, you can still choose. If the patient doesn't like the approach that one plan is taking,
but
they
there's
got to
be that balance.
Yeah,
right?
so it's very difficult. These are difficult calls.
Right,
Absolutely.
but I'm trying to say here is that we share the desire for the patient to get what the doctor thinks the patient needs, but we want to get overall cost savings. So let's work together to try to address that concern. The other thing is high-cost specialty drugs don't have any competition, and the PBMs don't have any leverage, what you were just talking about, to use competition to lower net prices. Would you be open to negotiation to lower drug prices in these cases where competition simply doesn't work?
So we'll be I'm happy to work with you on ideas that keep the patient at the center. You know, we propose foreign reference pricing in Part B, where we don't have a competitive mechanism for pricing, and we're happy to look at different approaches that create proxies for effective pricing there.
Okay, I yield back, but thank you very much, Secretary Azar, and I hope, Madam Chair, that we're able to make some concrete progress with our Republican colleagues on this.
I agree with you. Now I'd like to recognize the gentleman from Georgia, the patient, Mr. Carter, for 5 minutes of questioning.
Thank you, Madam Chair, and Mr. Secretary, thank you for being here. Excuse me, Mr. Secretary, as you know, for the past 4 years, I have been the only pharmacist currently serving in Congress, and I currently remain the only pharmacist. Prescription drug pricing has been something that's extremely important to me and something that I've concentrated on, and I want to thank you for your work, and thank you and your staff in particular John O'Brien, who has done an outstanding job in helping us. And this is something you're familiar with. You're familiar having been a CEO of a pharmaceutical manufacturer, and that certainly gives you a unique insight. But I've dealt with it in over 30 years of practicing pharmacy and seeing the evolution of the middleman, of the pharmacy benefit managers, the PBMs, and the abuses that I feel like that they have had over the years. And now the administration is finally addressing that. And I can't tell you how much that means. And Mr. Secretary, I feel like this will be your legacy, and I think it's an honorable legacy, and I want to thank you for that. And this administration as well, as was mentioned, this administration has made this a top priority, and I think it will be one of their legacies. And there could not be a more honorable legacy, in my opinion, after having practiced pharmacy for over 30 years and seeing the impact that high prescription prices have on people. I've seen it at front counter. I've witnessed it. I've seen senior citizens have to make a decision between buying medicine and buying groceries. I've seen mothers in tears because they couldn't afford medications for their children. This is very serious and something that is bipartisan. Representative Schroeder mentioned earlier a bill that we're working on in a bipartisan fashion, the Blocking Act, that will be brought up next week. That's something that's very important. We have to do away with the abuse of the generic manufacturers to delay the system like this. Two things that have been proposed by HHS. One has to do with DIR fees. DIR fees are atrocious. 2 weeks ago, I got a text from a pharmacist who showed me where they have been charged, his pharmacies have been charged over $300,000 in DIR fees for the year. Only this morning, I got another text from a pharmacist who owns 7 drugstores, $500,000 in DIR fees. Mr. Secretary, you can't stay in business in that kind of business model. It's just not feasible. Moving the discounts to the point of sale. I've always said that the most immediate, most significant impact we can have on prescription drug pricing is to have transparency. This will help bring about transparency. Only this morning, United Healthcare announced that they are going to move this into the private sector as well. This is exactly what we need. This is exactly what we've been fighting for. That's why I want to thank you for this. I find it interesting that in the rebate rule that HHS and OIG, that they've asked for 3 different scores. That's a little bit unusual, isn't it? Can you explain what's come about with that?
Yep, absolutely. So the reason there are multiple scores in the proposed rule, and we wanted to be transparent about it, so we published them, is our actuary from CMS came out with a score, and you're trying to predict the behavior of private market actors, and I'm sorry, actuaries are well-meaning, but they don't predict how businesses and private actors will behaviorally change. You all see that with CBO and so-called lack of dynamic scoring around legislation. We have the same issue on regulations, and so we wanted to get these different perspectives of what might happen in the marketplace. I firmly believe that if we can work together to get this rebate rule out, we will bring $29 billion of savings to seniors at the point of sale at pharmacy starting January 1st. And I believe that we will keep premiums stable in Part D because it's a highly sensitive marketplace to premium. And I believe the Part D plans will manage that effectively. I think it will get list prices down. It's, I think, the best tool we can have to completely change how drugs are priced in this country for the benefit of our citizens.
I couldn't agree with you more. Mr. Secretary, I just thank you for that, and thank you for your efforts in this, and I hope you'll continue on with this. This is exactly the route we need to be taking, exactly the direction we need to be having. Moving very quickly to the 340B program. Look, we don't want to end the 340B program. It's a good program, but it needs some guardrails on it, and we understand that. And that's what we're trying to do, is just tighten it up, get some accountability, some transparency, make sure it's going where it was supposed to be going. We're not saying that anybody is cheating. We're just saying that it's not being done in the way that we intended it to be done. Your comments on that?
We would love to be a partner with Congress and this committee on how we can bring that kind of transparency, oversight, and keep 340B effective for the purposes it was intended.
Thank you, Mr. Secretary. Again, I want to thank you for your work. Thank your staff for their work, the administration for this. This is about the patient. This will bring about lower costs for patients. It will bring about more accessibility, more affordability, and better health care in America. Thank you, Mr. Secretary.
Thank you.
Thank the gentleman. I now am pleased to recognize Dr. Ruiz from California for 5 minutes of questioning.
Thank you, Madam Chair. Secretary Azar, I'm an emergency physician, and from the Coachella Valley farm worker community where I grew up, to the hospitals where I worked as an emergency medicine physician, to the alleys and parks where I practiced street medicine, I've seen so many examples of how inadequate access to health care has devastated families, communities, and local economies. Passage of the Affordable Care Act, including Medicaid expansion, has dramatically improved access to care, According to California Healthcare Foundation, Medicaid enrollment in the Inland Empire region of California, where my district resides, increased by 57% in less than 2 years after Medicaid expansion. Instead of enacting policies that would shore up healthcare coverage, this administration has worked to undermine the ACA. In addition to selling junk health plans, dramatically rolling back enrollment outreach efforts, and refusing to make cost-sharing reduction payments, this budget continues to try to repeal the ACA, turns Medicaid into a block grant program, and imposes barriers like Medicaid work requirements. In my districts and across the nation, the effects of the budget would result in increased premiums, increased out-of-pocket costs for consumers, and more people without insurance. According to data from Georgetown University in my district, 1 in 4 adults are covered by Medicaid, and 58% of children are covered by Medicaid or CHIP. Cutting this coverage is unacceptable, and I will stand up for my constituents and the millions of Americans across the country that rely on these programs. In addition, Secretary Azar, I would like to discuss the administration's final rule on the Title X Family Planning Program issued late February that would make it more difficult to access essential services like birth control, HIV and STD testing, women's and men's health care, and pregnancy testing for individuals in underserved areas. This rule would directly hurt 4 Title X funded health centers in my district and thousands of my constituents who are served by them, often in underserved areas. Let me explain. The final rule prohibits Title X providers like those in my district from referring their patients for abortion services despite being allowed under current law, and even if the patient specifically requests it. Never mind that Title X already cannot fund any abortion. But that means doctors won't be able to provide the best medical advice to their patients. It also requires all Title X grantees to have strict financial and physical separation from any activities that fall outside the program scopes. That means a facility where 97% of the services are for prevention, cancer screenings, oral contraceptives, STD screenings, would not be able to receive Title X funds. They would have to, in order to receive these funds, build an entire different facility, which is costly, cost prohibitive, and they won't be able to do that. What most likely will happen if this is allowed to go forward is these clinics will shut down, making breast exams, pap smears, and other critical healthcare services unavailable for those who need it. So I want to get your sense, Secretary Azar. Do you believe that the Title X program has successfully served as a source of critical preventative care for patients?
The Title X program is very important. It provides important resources, contraceptive and comprehensive family planning for individuals, and that's why we fully funded it. But we also want to ensure the fiscal integrity of the program.
So let me ask you, then why has the administration chosen to move forward with changes to the program that would drastically alter how the current program operates and how patients can receive care?
By definition, in the example you just gave, federal taxpayer money is being used to support the provision of abortions. It's subsidizing that. If they wouldn't be able to run that business independently absent our Title X money,
but those monies cannot go towards abortion. Those monies help for breast exams, pap smears, and other preventative services. That's what they use those monies for. It is illegal for them to use that money for abortions. Can you explain why you believe that withholding necessary information from patients from doctors, even when specifically requested, even if a patient specifically requests, what are your referrals, where can I go if I'm considering an abortion, et cetera, is appropriate under medical ethics?
So under the final rule, we allow, as the statute allows, non-directive counseling, including related to abortion, and the provider is allowed to provide a list of service providers, including those that do provide abortions, but they're not allowed to just pick up the phone and actually directly refer them over.
Okay. Do you believe this rule will increase access to care for patients served by Title X?
I think we actually may see an influx of additional providers willing to come in and be part of Title X, and these are fiscal integrity provisions.
So in terms of access, in terms of a young woman's ability to get their pap smears going to an underserved area where the only providers are those receiving Title X funds, 98% of their services are for oral contraception, family planning, counseling, and breast exams, as well as pap smears, et cetera, for cancer prevention. You think by defunding them or making it hard for them to function in their clinic when they're the only clinic in that community is going to increase healthcare access for women?
Not allowing them to, through the Title X program, affiliate support abortions.
I would take that
shouldn't be a problem, shouldn't in fact impact their
Well,
operations.
it will. That's the whole point of this conversation, is that it will. It creates barriers for those individuals who provide 98% of their services, basic primary care, to deliver on those services.
Gentleman's time has expired. Important conversation. Thank you, Dr. Ruiz. I'd like to now recognize the gentleman from Montana, Mr. Gianforte.
Thank you, Madam Chair. Secretary Azar, thank you for coming before the committee today. I want to note for the record that after hours of testimony, you look fresh and energetic. I appreciate your endurance. I have 4 topics I want to touch on quickly, if I could. Many in Montana, especially our rural communities, struggle with meth and opioid abuse. The rural nature of Montana makes it challenging to ensure these individuals have access to treatment. The President's budget requests $120 million for the Rural Communities Opioid Response Program, which supports treatment and prevention of all substance use disorders in the highest risk rural communities. Could you touch briefly on how this program will help focus resources on reducing meth and opioid abuse, particularly in underserved communities?
Absolutely, thank you. And we're very concerned about not just the opioid issues, but any type of substance use disorder, especially in our rural areas. So that's why the program Congress, on a bipartisan basis, enacted with the Rural Communities Opioid Response Program last year is so important. 95 one-year R-Corp planning awards were made to support rural communities to identify opioid use disorders in their communities and develop plans to resolve these issues. And we're going to introduce additional awards in FY 2019 that we hope will yield large-scale organizational and infrastructure improvements at the rural and state level. And we also are going to develop a program to support rural and critical access hospitals, as well as Medicare-certified rural health clinics in an effort to expand MAT in rural communities.
Yeah, okay, thank you. And our office stands ready to help, particularly with rural. I want to switch topics. Suicide is among one of the leading causes of death in the United States, exceeding the rate of death for car accidents. Unfortunately, Montana has the highest rate of suicide per capita in the country. What's the administration doing to help us reduce the deaths from suicide?
Yes, so on serious mental illness and mental health care, we've invested, I believe, it's over $1 billion in the budget is dedicated to towards serious mental illness. Suicide, as you know, is the 10th leading cause of death for adults, 2nd leading cause of death for our youth. At SAMHSA, our largest mental health program, the Community Mental Health Services Block Grant, actually provides formula funding to enable states for serious mental illness and emotional disturbance. The Community Mental Health Services Block Grant is funded at $722 million. Our total mental health budget is actually $1.506 billion just in SAMHSA. And our suicide prevention program is $74 million. And another very interesting program is the Assertive Community Treatment for Adults with serious mental illness. That's actually increased to $15 million, allows a much more interactive approach to individuals who are facing risk of mental illness and suicide.
Okay, I appreciate your attention there. It's critically important to us back in Montana. Switching topics again, 18% of Montanans are over the age of 65. Your budget would allow these seniors to expand their ability to have health and medical savings accounts. These are options that are widely supported and encourage people to save for their health care needs. Can you just briefly detail how this works and why it's a good idea?
So what we want to do is expand the ability of individuals to use tax-free savings to assist them in building the health care that they want. So for instance, our health savings account proposal, we want to allow you to save more money. We want to allow the health savings account to be used not just for high deductible plans, but really any plan that achieves a 70% actuarial valuation. That's a technical insurance term, but it basically would allow HSAs to be used more frequently, expanding the use of, I think, the old Archer, the Medicare savings accounts to expand. It's been a fairly small program. We want to just create more options, especially in rural areas, and to take the money and be able to seek out alternatives that meet your needs.
My last question, and you'll be happy to hear it's a yes-no question, an easy one. Montana farmers grow a diverse range of crops. Last Congress, I signed onto a bill that would allow industrial hemp farming and the bill was signed into law as part of the Farm Bill. Now that hemp is legal, I'm glad that the FDA has begun thinking about how to regulate CBD. Dr. Gottlieb had stated that the FDA planned to hold a public meeting on CBD regulation in April. Is the FDA still planning on having this hearing? Now that we've had a change in leadership. Okay, so that's still going to occur.
It's an important issue. We've got to figure out how we deal with CBD oil and the constituent element issues around marijuana, so absolutely.
Great.
Yes.
Well, I want to thank you once again for your hard work. We have to work together across the aisle to get healthcare costs down and maintain access, and I appreciate your leadership. And with that, I yield back.
Thank the gentleman. Now it's a pleasure to recognize the gentlewoman from New Hampshire, new member of Energy and Commerce and the Health Subcommittee, Ms. Custer.
Thank you very much, Madam Chair, and thank you, Secretary Azar, for your patience with us. It's been a long day for all of us. The ACA helped millions of Americans enroll in affordable comprehensive coverage. The law's Section 1332 provides states with flexibility to experiment with health reforms, but the law makes clear that states seeking 1332 waivers must provide comprehensive affordable coverage to a comparable number of residences under the ACA. I have a few yes or no questions on 1332 waiver guidance. Simple yes or no. Are you aware that the guidance could substantially raise costs for Americans with pre-existing conditions?
The guidance is guidance. We would have to see an individual request from a state. Nothing in the guidance changes the ACA. It just says to states,
well,
please come in with
vis-a-vis
plans if you want to
pre-existing conditions, if they did not have coverage, would you agree that it would be more expensive?
We are not able to approve any plans that waive pre-existing conditions coverage under 1332. I think that's just bedrock solid is my understanding.
Are you aware that the guidance could substantially increase consumers' out-of-pocket costs and monthly premiums?
Guidance cannot do that. A state plan would have to come in with a request, and that would certainly be something that we would evaluate as part of that process. The guidance is simply saying to states, you can come in with plans, we'll look at them. There's no commitment to approve.
Well, would you acknowledge that insurance companies could substantially reduce the benefits that the product would cover?
I don't know that we can, I don't know that under 1332 we're able to waive the essential benefits coverage. I'd have to check on that to get back to you on that.
Do you think it's appropriate to spend taxpayer dollars on junk insurance plans rather than comprehensive coverage for Americans?
So one Washingtonian's view of junk could be to somebody in rural New Hampshire, their lifeline of some insurance, some form of insurance that they couldn't afford. You know, 29 million Americans still are lacking insurance, and we're trying to make other options available for people. Short-term limited duration is one, expansion to HRAs. No one's talked about this, which could actually add 10 million people into the ACA exchanges through the HRA regulation that we've proposed. So we're just trying to make more and more options available.
Well, can you explain why HHS sidestepped the full rulemaking process in promulgating its guidance?
The 1332 guidance was promulgated actually using, I believe, the identical processes that the Obama administration used in putting out their 1332 guidance.
Did your department's general counsel provide a legal opinion on the guidance, including on the statutory guardrails and whether the guidance should be subject to the APA?
I don't know, but I presume so, because any action coming out would normally be subjected to legal review, but it was put out exactly the same as Obama put out.
Will you commit to sharing this analysis with the committee? I'm focused on your administration. Would you commit to sharing this analysis with the committee?
We'll look at it and determine if it's appropriate to share in terms of
And you'll get
privilege.
back to the committee on that?
Absolutely.
And the statutory text is clear that a state waiver must meet these 4 guardrails specified in the law. Do you agree that any state waiver has to meet the guardrails specified in statute in order to be approved by your department?
Well, of course, we have to act consistent with the statute, and we will do so.
And if a state submitted a waiver application that would provide less comprehensive or less affordable coverage to its state residents, would your department approve it?
I think we laid out in the guidance an alternative way of looking at the comprehensiveness aspects. What we found was that the previous administration had so interpreted the comprehensiveness aspects that no states were actually, whether red, blue, whatever, were willing to come in with requests because it was so confining and lacking in flexibility, and we thought violated the
Well, will
intent of
you commit to upholding the law and only approving 1332 waivers that meet the guardrails specified in the statute?
We certainly will only do so to meet the guardrails in the statute. We may, in candor though, you and I, our administrations, may differ on what it means in terms of what it may mean in terms of the comprehensiveness. I just want to correct something, if I could, ma'am. Essential health benefits are actually waivable in the guidance. I misstated that. I misrecollected, so I do want to clarify. I'm informed that essential health benefits would be waivable, and that's why we
I'm going
did
to
open the
switch
door to
gears
short-term
now,
limited
if I could
duration
reclaim
plans.
my time.
I'm sorry for the error
Is it
there.
true that your requests in the budget cuts $52 million from SAMHSA mental health programs?
There may be a part of it that does cut a part of the program
And
that we find less
$31 million from substance abuse treatment programs?
Well, we can play these games. There's $1.5 billion of serious mental illness and mental health programs within SAMHSA that we are requesting.
But for example,
funding
the ONDCP has been cut completely, or that is funded?
First, ONDCP is not part of SAMHSA. What happened is the one program which SAMHSA already administered, I believe the funding for that was actually moved over to SAMHSA to regularize how that's administered. I believe
I'm sorry, my time is over. I'm just trying to follow this bouncing ball because I think SAMHSA actually is losing over $160 million for this program with this trick of moving the ONDCP funding, but I yield back.
We thank the gentlewoman. I'm now pleased to recognize the gentleman from Missouri, Mr. Long.
Thank you, Madam Chairwoman.
5 minutes of questioning.
Thank you.
And a few seconds of something lighthearted.
I'm sorry?
And a few seconds of something lighthearted.
I tell you, it's been a long day. I tell you that. I don't know how much of that I've got in me right now, but had another subcommittee hearing most of the day while I was late getting in here, and I hope I don't repeat anything that was said earlier. But Secretary Azar, I want to thank you for being here today, and I understand you've been here some 4 hours now, and want to commend you for all your hard work for all of us that you do, and also want to recognize President Trump for proposing a fiscally responsible budget which reflects the reality of the Budget Control Act. Can you detail what your priorities are and how you worked to restrain spending in light of the current law?
Thank you very much, Congressman. As you know, we're trying to submit a budget that complies with the CAPS agreements. We've submitted a budget that tries to comply with the caps, the budget caps that the Congress and President Obama actually put into statute. And so to do that, it requires tough choices. So the prioritization that we used in looking at our budget, working with OMB and the White House, has been first fiscal discipline. So make sure that we're contributing across the board to the overall functioning of the budget. Second is ensuring responsible stewardship of taxpayer dollars. We actually eliminate 90 programs that we find to be ineffective or less effective than others, supporting and prioritizing direct service delivery. So where are we actually providing health care or human services to people as opposed to capacity building, and providing flexible funding to states and others rather than just categorical programs. So those would be some of the ways. Obviously, there are some other areas like opioid funding that we have prioritized, ending the HIV epidemic that we have really prioritized funding. And bioterrorism preparedness, of course.
Yeah, I always say that of the 435 congressional districts, there's 435 of us that will swear that our district has the worst opioid epidemic in the country. So it's a huge problem. As you're well aware, the Community Health Center Fund expires on September 30, 2019, and the budget proposes to continue funding them at $4 billion in mandatory resources for each of the fiscal years 2020 and 2021. How do community health centers serve as a gateway to integrated care for individuals with mental illnesses and substance disorders?
The Community Health Center program is absolutely vital to our efforts around substance use disorder, mental health, primary care provision. So as you mentioned, the budget that we have on the health center program, in that budget, in the FY 2020 proposal, we continue the $544 million of ongoing annual investment and expanded mental health and substance use disorder services related to the treatment, prevention, and awareness of opioid abuse, which were initially awarded in FYs 2016 through 2019.
Okay.
Community health centers are increasingly using telehealth, which is very important to rural districts like mine, to better meet patients' needs, especially in those rural areas where residents face long distances between home and healthcare providers, and sometimes it's just not worth it. Elderly don't want to drive 70 miles to get services or 100 miles or whatever the case may be. Do you see the value in allowing more use of telehealth in health centers?
I am a passionate believer in telehealth, especially as part of how we need to bring services to rural areas and other underserved areas. The HRSA Telehealth Network Grant Program is part of that, which provides funding. But we want to keep working with Congress to find other ways to help address the rural health care crisis in the country and the underserved crisis. Telehealth has to be a part of that.
HHS developed the Reimagine HHS plan to increase efficiency of the department. Could you talk a little more about this plan and how it can improve the functioning of HHS's programs?
Thank you very much. So with Reimagine HHS, what we did is it's essentially taking the president's management agenda and looking at this $1.3 trillion agency with 80,000 people. And we talked to our career people. I've got just tremendous respect over the 2 decades that I've been around HHS and the career officials we have at our department. And we did a bottom-up process asking them, if you could run HHS differently, what would you do differently? And so first, we want to make HHS the best place to work. We want high employee engagement. We want people to feel very fulfilled in the important mission of our work. We want to improve NIH's operations. So part of Reimagine HHS is to create essentially regional hubs within NIH where we can optimize several platform services there. Not a single service provider for all of NIH, but create some collaborative hubs that will save money and hopefully improve efficiency and improve quality. We want to reform our acquisition processes so that we can buy smarter. Just a couple of examples of just good common sense ways to run a massive department better using the genius of our own career people.
Okay, I'm going to have to stop you there. I don't have any time left, but if I did, I'd yield it back.
That was generous. He is known for his generosity. The patient, gentlewoman from Illinois, Ms. Kelly.
Thank you, Madam Chair.
Kelly.
Thank you. I think we can all agree that regardless of political affiliation, we should all want to ensure that children have access to health care. After years of decline, recently the number of uninsured children in this country has been significantly increasing. In 2017, the first year of the Trump administration, according to the American Community Survey conducted by the Census Bureau, the number of uninsured children increased by 276,000. And according to HHS's data, in 2018, the number of children enrolled in Medicaid and CHIP declined by nearly 600,000. There is no data showing that the number of children enrolled in private health insurance coverage increased by 600,000 over the same period. So it's pretty clear that hundreds of thousands more children will be uninsured. Since all of this is happening on your watch, I have a couple of questions. Your CMS administrator, Seema Verma, likes to say that Medicaid will always be around for those who truly need it. But according to these numbers, there are a significant number of children who are losing health coverage under Medicaid and CHIP, and many children going uninsured. Secretary, just yes or no, are low-income children included in your definition of those who truly need Medicaid?
Absolutely. They're one of the core populations of Medicaid, of course, as well as our S-CHIP program. Absolutely, the low-income children are a core of that. Of the traditional, I mean, that's part of what we want to do is really make sure we're not losing our focus on some of the core populations Medicaid was built for, and low-income children, absolutely.
What does the president's budget propose to stem the increase in return uninsurance rates among children to the historically low rate that the president inherited in 2016?
So we haven't, to my knowledge, and if we have, I'd like to know if there's something that we have done in regulation or otherwise in Medicaid that is impacting that and access to Medicaid for low-income children. Please, let's talk about that. I'd like to know that.
Okay.
And then we can build interventions around that. So I would like to solve the problem. I'm glad you're highlighting this for my attention, and happy to work with you on that.
Okay, would love to. In some states, you have approved waivers to take away health coverage from parents who fail to work a certain number of hours each month. We know from research that when parents have health insurance, their children are more likely to be covered. Another yes or no question, can you guarantee that no children will be affected by their parents' coverage loss in those states?
Children should not be impacted by any of the work engagement or the work requirement or community engagement programs that I'm aware of in terms of the waivers that we've granted. Even if the parent were to come off, they would have been qualified as able-bodied under Medicaid expansion populations. I want to double check on that though, if I could get back to you there. I would be very surprised if that would impact child coverage, but I just want to make sure that that I'm being accurate with you. If I could get back to you on that to be sure, if you don't mind.
And just changing a little bit, I was asked by some young people to ask this. Menthol cigarettes have had a particularly devastating impact on young African Americans. 7 out of 10 African American youth smoke menthol cigarettes. We prohibit tobacco companies from using cherry, strawberry, and other flavors to attract kids. It has been 4 years since the FDA announced that it would issue a proposed rulemaking on menthol. Can you assure me the FDA will soon issue a proposed rule to prohibit menthol cigarettes?
So I share your concern about menthol as an additive in tobacco. I share the public health concern about attractiveness, especially in the African American community, and some of the data that we've seen around possible fostering of addiction or attractiveness there. We want to make sure we're gathering all the public health information on this, and so I do anticipate that we continue to run processes to learn here. I don't know that the first step would be a regulatory action as opposed to initiating a process to make sure we have to build the public health base very solid with evidence on rulemakings in that space. But I know your concern. I share your concern. Commissioner Gottlieb shares that concern. He addressed that in some public comments he made recently. And so we want to keep moving on that, but I don't know the exact mechanism that the next one would be.
I'll report your answer back.
Thank you.
I yield back the rest of my time.
Okay, let's see. And now I'd like to recognize the gentlewoman from California, new member of the full committee and the subcommittee, Ms. Barragan.
Thank you, Madam Chairwoman. Mr. Azar, thank you for being here today. Have you had a chance to visit the Homestead Detention Facility in Florida?
I have, yes.
When was that?
It would have been about a month or a month and a half ago that I visited.
Do you remember when you visited the facility, roughly how many children were being housed there?
I may have that information. It should have been relatively stable. I believe, I don't have the actual census in front of me now. I don't want to speculate on a number.
Okay.
I just don't have that in front of me at the moment.
And the Homestead facility, it's a temporary shelter, is that correct?
It's what we call a temporary influx shelter. What we do, because the inflow of unaccompanied alien children across the border is so unpredictable, we build permanent shelters.
Right. This is a temporary one.
We have temporary influx to give us flux capacity, but we keep working to try to add permanent capacity because we would much prefer permanent capacity to temporary influx.
Okay.
Absolutely.
So when it's temporary, there's no requirement to get a license from the state of Florida. Is that correct?
So the temporary influx shelters are not subject to state licensure, but they're subject to all of ORR's regulatory requirements, yes.
Well, the permanent facilities have different requirements, is that right?
A permanent facility actually does have to be licensed by the state as a temporary influx.
Okay, I just want to make sure we're clear. The permanent facilities actually do have regulations that are followed. The temporary ones don't have to follow those same regulations as the permanent ones.
They do not have to be state licensed. They still have to follow all of ORR's regulatory and practice requirements.
Right, and they're different. I just want to know for the record that they're different, and a temporary has different requirements than a permanent one.
That is correct.
Okay. Why are we running emergency unlicensed facilities when there has been no unexpected surge of unaccompanied minor arrivals?
No unexpected surge. We have had 120% unaccompanied alien children coming into this country in February over last year. I'm sorry, we're in a crisis.
There's no surge, though, sir. If you take a look at your own numbers, in February 26, 2019, there was, I was told there was 1,600 per your own, actually it's your own release that I have here, 1,600 unaccompanied minors were housed there. There have been many, many more in the past, and there has been no surge to need a temporary facility in which children are being treated differently. Let me ask you, Mr. Secretary, about your visit when you were there. When you visited there, did you get to see the rooms that are really cold, where immigrants are being packed like sardines there? Did you see that when you were there?
I saw dormitory rooms that had, I think there were 10 beds in the rooms that had air conditioning. You're in southern Florida, they had air conditioning. Sometimes the kids do complain that we keep the temperature a little cold.
Sir, I'm asking you a very specific question. In your assessment when you went to go see there, did you see children being packed into these cold rooms?
Of course not.
So you did not see what other people are seeing? You did not see 70 to up to 250 kids in these rooms?
Oh, so if what you're referring to is not the dormitory, the age 17 part of the facility on, I think it's the North Campus, does have congregate living for the 17-year-olds, I believe it is, and they're in a large open area. And interestingly, I asked about the exact thing you're asking, and what I was told, it may be incorrect, was that the kids actually prefer, that 17-year-olds actually prefer that more open congregate setting.
Do we let the kids decide if they want to, how they want to sleep? My understanding is that beforehand, most kids would sleep in rooms of 12. Now you have children in these large rooms that sleep up to 70 to 250 kids. From my reports that I've seen, it's inhumane the way kids are being treated there. It's inhumane that they're being situated there. They're certainly not a family setting. Would you say it's a family setting there?
I would just dispute inhumane. I met with the student council representatives.
Do you feel like it's a family setting there? Everything I've heard is it's like a prison. And the kids, they form lines and...
I've got to tell you, these...
Do you think that's an inaccurate assessment?
It disgusts me when people refer to the grantees.
Mr. Secretary, I'm just asking you a very simple question. Do you think it's like a prison setting, or do you disagree?
No, I do not.
You do not think it's like a prison setting?
No, I do not.
Okay. I want to ask you really quickly, sir, because my time is expiring here. Do you agree that any time that a child is abused in the care of ORR, that's one too many children?
Any child abused is one too many child abused. Absolutely.
Okay. There have been reports of thousands of children who have had sexual abuse incidences in ORR custody. Do you know of any where there have been against staff?
I'm sorry, where what? Anywhere?
Any complaints where there have been against staff?
Against staff? Against ORR staff?
Yes.
Absolutely not.
You don't know one incident?
ORR itself does not take care of the children. We have nonprofit grantees who take care of children.
But they're under your
No, but you asked about ORR staff. The grantees, we've received in the past 4 years over 4,000 complaints, including in the Obama administration, about 1,000 sexual misconduct. Of those, 178 over 4 years involved allegations of children regarding staff members' adult minor sexual abuse, all of which are reported to authorities and investigated. We'll actually be putting a report out soon with showing a very high rate of those being unsubstantiated, but we take each one deadly seriously, absolutely.
Well, they're under your jurisdiction, sir.
Time has expired. I thank the gentlewoman, and now I'd like to recognize the gentlewoman from Delaware, Ms. Blunt Rochester, for 5 minutes of questioning.
Thank you, Madam Chairwoman, and thank you, Secretary, for being before our subcommittee today. Mr. Secretary, I get a lot of visits in my office. Even as recent as today, I had folks come in from the American College of Obstetrics and Gynecology. I had women from the sorority Delta Sigma Theta. There's a lot of concern, number one, about the budget proposals, everything from NIH funding to Medicare and Medicaid cuts. But one of the big things that people focused on was the real rollbacks to the Affordable Care Act and what people have witnessed as, from day one, actions that the administration and your department have taken that have made it much harder for Americans to access and afford the vital health insurance coverage that they rely on. The administration has undermined the health insurance market by cutting off cost-sharing reductions, gutting ACA marketplace enrollment periods and outreach, reducing funding for the Navigator program, while promoting the sale of short-term limited plans, also known as junk plans, which don't comply with the ACA consumer protections, don't provide adequate health care coverage, and provide financial protections for families. And so my question, the first question is, Mr. Secretary, your department recently proposed a rule that would change the formula for the ACA subsidies. Your department's own analysis acknowledges that the proposed policy would increase premiums for 7 million individuals and cause hundreds of thousands to lose coverage. Mr. Secretary, in deciding to propose this policy, did you consider the fact that it would increase premiums and out-of-pocket costs for millions of Americans? And that's just a yes or no question.
I want to make sure I'm understanding what you're asking about. I think you might be talking about the notice with the premium indexing. Is that what you're referring to? Because with the notice on premium indexing, it had been indexed just to employer increases in premiums. We proposed to actually index the premium contribution based on a metric that would include employer as well as the individual market premiums as the basis for what the individual maximum required contribution towards insurance coverage is. So,
but is it correct that it would increase premiums for 7 million individuals?
The indexing, by increasing the index, it would increase for some individuals.
So
I don't know the 7 million, but it would increase, yes. The indexing increases to account for that.
Okay, so 7 million people. Mr. Secretary, your department also requested comment on a policy that would end the practice of automatically re-enrolling consumers in the marketplace. The department acknowledges that 2 million Americans rely on automatic re-enrollment. Approximately 2 million individuals could lose coverage if the department terminates this policy. So you're basically getting rid of one of the easiest pathways for Americans to get health coverage. The department has also made a concerted effort to make it more difficult for people to obtain coverage in the exchanges by drastically reducing funding for outreach and education activities. As we mentioned, gutting the Navigator program and limiting the time of enrollment, ultimately giving consumers less opportunities and less time to make informed choices. Secretary Azar, can you commit to ensuring that Americans wishing to enroll in coverage are well informed about the opportunities to enroll?
I think they are, and we see those results, I believe, through the enrollment numbers, which show actually a fairly consistent pathway on enrollment numbers year over year. And we saw, I think, historic levels of 90% satisfaction with call center interactions. We didn't even have to use the waiting room in the call center, I think, for the second year in a row. So I think
I'm just going to jump in for a quick minute because I don't have that much time, but I know that it has been a challenge for folks to do the outreach, and I know that the budget in the past was cut by 90% for marketing and outreach, and so if you could share with us specifically with that kind of cut, what do you propose to reach out to folks?
So, we've had that consistent with last year and this year. We've had more limited federal spending around outreach, and what we have done is relied on the private plans who have every incentive to get people enrolled in their plans to do so, and we've seen a very efficient and effective enrollment seasons where I believe they've stayed relatively consistent, certainly in light of economic indicators, and so I think it's actually working. They're bearing the burden.
You mentioned also something about enhanced disclosure. I'm sorry, I only have 10 seconds. For the so-called junk plans, can you talk about what does enhanced disclosure actually mean?
We required that they very clearly disclose that this is not compliant with the Affordable Care Act EHB provisions.
It's just inconsistent to cut off the marketing and outreach, but at the same time, you're acknowledging that you need enhanced disclosure and more information to people. So I hope that my goal is that we would really make it more available to people, easier for them to get automatic enrollments, and more time for people to make informed choices. And thank you for your patience as well for being here.
I thank the gentlewoman for her excellent questions. Now I'd like to recognize the gentleman from Illinois, Mr. Rush, for 5 minutes of discussion. And then we will be moving to the second round of questions, and there are designated members that will participate in that. Mr. Rush, 5 minutes.
I want to thank you, Madam Chairman. Secretary Azar, studies have found that short-term, limited duration health plans, often referred to as junk plans, engage in deceptive marketing tactics, and insurance brokers who sell these plans fail to provide consumers with detailed plan information. I'd like to share a story that a patient, Sam Bokal, a 29-year-old patient from Chicago, wrote in a testimony submitted to the subcommittee earlier this year at a hearing entitled Strengthening Our Healthcare Systems, Legislation to Reverse ACA Sabotage and Ensure Pre-Existing Conditions Protection. Sam enrolled in a junk insurance policy after an insurance broker misled him about the benefits covered under the plan. Sam had been experiencing back pain. After enrolling in a junk insurance plan, Sam was diagnosed with cancer. His insurer refused to pay for his treatment, claiming that the cancer was a pre-existing condition that was not covered because Sam should have known that cancer was the cause of his back pain. He was left with almost $1 million in medical bills. Mr. Secretary, your department acknowledged that consumers who purchase junk plans and then get sick or, quote, develop chronic conditions could face financial hardship as a result, end of quote. Mr. Secretary, yes or no, do you think that it takes this country in the right direction to go back to the days when a policy could be rescinded if you get sick or if you get declined for pre-existing condition? Yes or no?
We don't believe that. We believe people should have the option to have their pre-existing conditions covered. The short-term limited duration plans, though, are helpful for the 29 million
Thank you,
Americans
Mr.
who got
President.
shut out of the
Secretary,
Affordable Care Act market.
A study by the Georgetown University Health Policy Institute found that many consumers enrolling in these deceptive plans are led to believe they are purchasing comprehensive policies when in fact they are not. Plain and simple, these plans are nothing but garbage. The same study found that brokers often fail to disclose to consumers that junk plans are not comprehensive coverage and will deliberately steer consumers toward junk plans. For example, brokers selling junk plans over the phone pressure consumers to quickly purchase these plans without providing written information, including information on the benefits covered. Mr. Secretary, are you aware and that you consider in rulemaking that these plans often engage in aggressive marketing and that means people do not understand what they are buying? Yes or no?
So yes, we enhanced the protections compared to what the Obama administration had around the short-term duration plans that they had in their rulemakings.
Mr. Secretary, are you aware that insurers of these junk plans commonly engage in the practice of post-claims underwriting, as the Insurance Commissioner of Pennsylvania testified before this subcommittee?
These plans are subject to state law and regulations, so that would be that insurance commissioner's issue on how to regulate these plans.
Secretary Azar, as Sam writes, sometimes someone with insurance should not have to worry about filing for bankruptcy or not having access to life-saving treatment. These junk plans are not about consumer choice and freedom. These products are a risk to people's health and to their economic security. I thank you, and I yield back the balance of my time.
As previously discussed with the minority, we'll now move to a second round of questions, which the Secretary has agreed to, from 3 Democratic members and 3 Republican members. I now would like to recognize Ms. DeGette of Colorado. let's see, how much time? are
5
we?
minutes.
5 minutes. Recognize her for 5 minutes in this round.
Thank you very much, Madam Chair, for recognizing me. Mr. Secretary, as you know, I'm the chair of the Oversight and Investigation Subcommittee, and we had hoped to have you here for our hearing that we had on the border separations, but we're glad to have you now. I wanted to just ask you a couple of questions about the zero tolerance policy instituted on April 6, 2018, under which nearly 3,000 children were separated from their parents. Secretary Azar, were you consulted prior to the issuance of this policy or are informed it was under consideration?
I was not aware that that policy was under consideration before the Attorney General announced it on April, was it April 6th or so?
Now, wouldn't you normally be considered, since HHS has the Office of Refugee Resettlement, which would be taking these children, wouldn't it be normal to consult HHS before instituting a policy like this?
I would have hoped so.
But they didn't talk to you beforehand?
No, not to me, no.
If you had been consulted, what would your recommendation have been?
I think it's very hard now, looking back with all that we've been through, to do 2020 backwards. You know, it's easy to Monday morning
You think you may
quarterback.
have said it was a good idea?
I hope that I would have raised the significant child welfare issues, the significant issues around
you're not sure if
program
you
and
would have?
reputational. I just want to be fair to my colleagues and everyone else. It's very easy in
Wait,
retrospect
let me ask you
to
this.
say
When
things.
did you learn about this? When did you learn about this policy?
So this policy, let's be clear, the Attorney General on April 6th announced zero tolerance.
That's right.
And then I believe it was March 7th announced that the implementation of the zero tolerance and 100%
March 7th is
referral.
before April
May
6th.
I'm sorry, May 7th. May 7th, zero tolerance.
So when
and,
did they start taking the kids from the parents?
I don't know when they first started. I learned about the fact of the zero tolerance, of course, when it would have been in the press April 6th.
When did
and
you,
then
as the head of HHS, learn that the children were starting to be taken from their parents and put into the custody of your
If you wouldn't mind, I'll be happy to tell you.
Very briefly.
So April 6th is, I would have seen it in the media or learned about it. I very quickly fell ill and was in the hospital for several weeks of hospital and home care in the month of April. Around when the Attorney General made his announcement of implementation, May 7th, I would have known about the fact that that was coming out, but I want to be clear, I did not connect the dots that zero tolerance and 100% referral meant implications for our program, nor was there any indication from discussions with me.
When did you learn of that?
It would have been in the days and weeks following the announcement on May 7th, yes. As
So,
we started
did
seeing
you-
kids and seeing media stories around that.
Did you talk to the Attorney General or anybody else about that?
I did not speak to the Attorney General himself about that, but we had there were various meetings.
Who did you talk to about
We
it?
would have talked to the Department
Who
of Homeland
did
Security.
you, Secretary Azar, talk to?
Talk to when and about what? And
In the weeks after May 7th, about this policy?
in the weeks after May 7th, our immediate concern was
So, no,
taking care of these
Who
kids.
did you talk to in the weeks after May 7th
I would have
policy?
talked and I would have spoken with the Secretary of Homeland Security routinely, the White House, the interagency policy process around immigration policy.
And what did you tell them at that time your agency's view was towards this policy?
So our focus was on how do we take these kids in and deal with the issues.
You didn't register an objection to it at that time?
I did not.
Okay. Now, Commander White came before the Oversight and Investigation Subcommittee. He told us he raised concerns with HHS leadership about the family separation policy. Did you know of Commander White's concerns?
I did not. In fact, I unfortunately did not know Commander White until I brought him in to help with this problem in June.
Okay. And you don't recall him ever telling you, or you never learned that he was expressing concerns throughout the agency?
No.
Okay. Can I just say, this is the frustration for us because he was there, you're here. We've asked for documents. Mr. Palone's going to talk to you about it, but I would appreciate it if we could get those email communications to find out what the agency knew. If you can work with us on that.
We're certainly working on that. I believe we've
one last
produced several thousand already, and we'll keep working with you on a rolling basis on producing
Thank
materials.
you. One last thing. There was an article in the New York Times on the 9th of March, and it said that the separations are still happening. There's 245 children that have been removed since the policy was reversed. And it also says that staff members have raised questions with Border Control agents and about what appear to be little or no justification. Do you have any knowledge of that?
Yes, I do. And
If you can please answer.
If I could answer. Separations have always happened, and they can continue to happen on the TVPRA as well as just child welfare principles. So DHS will send us children where they have where there's a felony conviction under the TVPRA. There's certain ones, especially violent crimes, where there's a concern about child welfare, where an individual claims to be a parent but isn't a parent. So we get those. In addition, my understanding is we get a small number of children at this point still where local officials use their discretion to prosecute the parent for a felony violation of immigration laws, only felony. We may have received some where it appears it was based only on a misdemeanor offense and prosecution. That's not the policy, is my understanding. I think our people, sometimes we don't always get full information why they were separated and sent to us, and so I think in fairness, some of our people have expressed concern about some cases saying, why is this child being sent to us? I don't quite know and understand why you separated them, and does it
I think your time has expired.
Madam Chair, I would just ask unanimous consent to place this New York Times article in the record, and also we will be sending follow-up questions. I would appreciate if the Secretary could answer that.
So ordered. Now I'd like to recognize the gentleman from Kentucky, Mr. Guthrie.
Thank you, Madam Chair. I appreciate it very much. And just to reiterate what was said, that because I was going to point this out, is the decisions to separate parents from their children were because of immigration enforcement decisions are made by the Department of Justice and carried out by DHS. My understanding is HHS hasn't separated a single child. And while I do support a strong enforcement of our borders by DHS and the Justice Department, I do not support separating families from their children. I don't know of anyone here that supports separating families from children. We want to keep children together. In a previous hearing, there were some allegations brought up about HHS, ORR, so within your cabinet or your department. So I just want to bring these up. And so recent reports have detailed allegations of abuse, including sexual abuse, of minors in ORR facilities over the past 4 years. This was an issue that this committee examined in 2014 upon learning of abuse detailed in reports published by the Houston Chronicle. I believe Dr. Burgess led that, and we remain concerned about recent reports. What is ORR's process for reporting and investigating sexual abuse allegations? And does this process differ depending on if the allegation is between two unaccompanied minors or versus an unaccompanied minor or child and an adult staff member?
Yep. Thank you. And obviously, any allegation of abuse or neglect against a child has to be taken very seriously, and especially sexual misconduct or abuse is absolutely unacceptable, and we want to work with you and make sure our processes and procedures protect against that. We receive 3 types of sexual misconduct that fit into that group of about 1,000 a year of reports that we've gotten over the last 4 years, including in the previous administration. There is inappropriate sexual behavior. That can be as little as a child saying something inappropriate to another child, inappropriate touching. It can be sexual harassment, again, could be child on child, or most seriously, sexual abuse. We received over the last 4 years, when we've had about 180 to 189,000 children in that period, 178 allegations of sexual abuse of adult on child staff member issues. Those sexual misconduct allegations must be reported to ORR within 4 hours. Sexual abuse cases must be reported to federal, state, local law enforcement officials, child safety, welfare individuals for investigation. ORR receives these investigations. We've put in place a full-time prevention of sexual abuse coordinator in this administration. We put together a committee to review allegations and ensure proper oversight. We receive reports on any developments in the case within 24 hours. So we try to aggressively pursue that. If we can improve our procedures, we are welcome to be a learning organization and get better and better at this. We do not want any of these cases ever to happen.
Okay, to clarify, it was in another committee and with a different secretary, and I know you've answered some questions in other departments, so we want to, they were asked about what's going on in your department, so I just want to clarify. So recently there's been some incorrect information regarding who the allegations are made against. When we say staff, allegations against staff, does that mean HHS staff or ORR staff or appointee or contractees, staff?
Thank you for asking for that clarification. These are allegations where it involves staff that would be staff of grantees. These are the nonprofit entities that run the approximately 100 facilities that we have to care for children. Obviously, we have oversight. We want a safe environment. We have to investigate. So it's not to diminish in any way responsibility that we have to ensure a safe environment. But to my knowledge, I'm not aware of any allegations against an actual HHS employer, OR employer with regard to these children.
So when you receive this, walk us through the process of, I know it may not get to your level, but what happens? I mean, what happens? So we understand how these children are being protected. I know that we all want the children to be protected. Obviously you do as well. So how do you react when I would say cabinet, that's what we call them in Kentucky. Your department react when you have an allegation?
So the process, especially when we get an a sexual abuse allegation, is that the grantee is required to alert immediately Child Protective Services and state officials for potential prosecution and investigation for child welfare. We are alerted within 4 hours. That goes to this National Sexual Abuse Prevention Coordinator. We have in each of our grantee facilities actually a hotline. It's like a telephone booth. If you visit our facilities, you should see that, where a child may make a claim of sexual misconduct through that reporting hotline to make sure we learn of it immediately. And then we conduct, of course, the regular oversight, and I hope we take swift, appropriate remedial action anytime there's a finding of inappropriate conduct.
So I believe there are 3 contractors that, I'm probably out of time, but 3 contractors that have been the most allegations have been against. Has anything happened with those 3 contractors?
So I'd say most of the allegations you've heard about involve a contractor in the Arizona area, and in that instance, we shut down before anything was public. There was a pulling hair incident that you might have seen a video of. Before that was ever public, we actually shut that facility down. We pulled our children out of it. We shut another facility down, I believe, pulled children out of it. We stopped placement of children in the other 6 facilities of that grantee, revoked their licensure, and for any facilities to come back online, they would have to go through the state licensing procedure, recertification, as well as OR being satisfied that the leadership, policies, practices, everything had changed sufficiently because we really have to ensure the safety of our children.
I thank the chair for her indulgence, and thank you for your answer. Appreciate that. Thank you.
I thank the gentleman for his important questions. Now the ever patient, ever present, Ms. Schakowsky from Illinois, is recognized for 5 minutes.
I thank the chair for allowing me to weigh on. This is such an important issue. According to the Government Accountability Office, months before the Attorney General's April 2018 zero tolerance policy memo was issued, the Office of Refugee Resettlement saw a 10-fold increase in the number of children who were separated from their parents. Furthermore, ORR officials told GEO that a few months prior to the April 20th zero tolerance memo, they considered planning for a continued increase in the separated children, but HHS leaders advised them not to engage in such planning. So, Secretary Azar, were you aware that ORR officials were seeing a 10-fold increase in the number of children who were separated from their parents?
I was not. I wasn't actually aware of an issue of separating children at the time, really, until we got into that May time frame.
I heard what you said, but according to Commander White's testimony in front of this very committee, the Oversight and Investigation Subcommittee, though, the HHS leaders who told him not to plan for continued increase in separated children were Scott Lloyd, the head of ORR, and Maggie Wynn, your counsel for Human Services Policy. So, Secretary Azar, before the issuance of the zero tolerance policy, did Mr. Lloyd or Ms. Wynn ever discuss family separation with you?
Not to my knowledge, and I'm disappointed that I didn't know that. I'm disappointed they did not tell me if they were engaged in
And
these
has there been
different
any
pilots.
consequence for them for not telling you something like separating children?
So the issue is what would we have done differently? Of course. So I am concerned.
Stop separating children is one idea.
First, we don't separate children, but the other is as I understand.
Go back to that.
We don't at HHS separate children.
I see.
We at HHS do not separate children. We receive children sent to us, and we just try to care for them the best we can.
Stop the policy, though.
I'm sorry?
You could have stopped the policy in some way, made us think about it.
Correct. If I had been alerted to it, I could have raised objections and concerns, absolutely. And I wish we had had more knowledge flow, and I wish more people had been engaged in these issues, absolutely, of course.
So you did, once you found out about all this, have you done anything at all in terms of raising this issue?
So once we found out about it in May, we scrambled immediately towards dealing with the issues that we were dealing with. What I told our team, I convened our team and I said, because I was seeing the same press stories you were seeing, and I was very disturbed by it. I said, I want every child to know where their parent is. I want every parent to know where their child is. I want every parent and child in regular communication, telephone or Skype, and I want us to begin immediate reunification processes to get them outplaced with sponsorship. Now, we use reunification differently than the later Judge Sabra order. Reunification means placing often with a level 1 or level 2 sponsor in the homeland. And so I pulled in our Assistant Secretary for Preparedness and Response to add logistics capabilities on top of our normal.
We're claiming nighttime. So tell me, Secretary Azar, as this nation's top health official, after separation began taking place, did you ever attempt to just put your foot down and stand up for the children and tell DOJ, DHS, or the White House that separation should be stopped?
All of that was preempted. The President on January 22nd issued his executive order stopping separations, and at that point we moved immediately towards compliance with the June 26 court order and reunifications. All of our efforts were focused on that.
Well, you say that, but did you read the New York Times on Sunday?
As I mentioned to Congresswoman DeGette, the separations that are currently occurring, to my knowledge, again, I don't separate children, are the types of separations that are normally happening for child welfare. They're from felony violations, for child welfare, lack of parentage. There can be some felony prosecutions. I believe those are fairly rare.
Okay, well, let me tell you what some of your staff said. Staff members have in some cases raised questions with Border Patrol agents about separations with what appears to be little or no justification.
And I am glad they are doing so, and I encourage them to do so. We don't always get, sometimes there's law enforcement sensitive
No, what are you doing? What are you doing? American people are horrified by this. They see this, I see this, as state-sponsored child abuse, I would say even state-sponsored kidnapping. Children being taken away from their parents, hundreds, maybe thousands of children, and it's continuing. I want to know what you are doing, a sense of urgency to come from you about what you are doing about stopping this.
I will not stop or advocate DHS to stop separating children from individuals who present a harm for child welfare, and if that is what is occurring and that is what should be occurring.
But you're the Child Welfare Agency, and you need to find out if these are legitimate because it's also said that some of your staff found that the border agents said, no, we're not doing anything about this. We're going to separate the children. That's in that article.
Gentlelady's time's expired. Gentlemen, the ranking member of the full committee, Mr. Baldwin.
Oregon. Thank you, Madam Chair. Appreciate it. Mr. Secretary, thanks for being here and taking on these tough questions. We appreciate it. And I want to go back to part of this again to make clear that your professionals do not separate children.
That is correct. We do not separate children.
And tell me, how many children show up at these ORR facilities on a given day? I mean, you probably get some count, and you don't control that flow, right?
We have no control over the flow of children to us. We currently have 11,668 children in our care. We received the other day, the last report, we received 229 children. We've seen rates
in a given 24-hour period.
In a day. We are seeing rates, it is surging. We are seeing rates upwards of 300 children coming over a day now. It is a 120% increase in unaccompanied alien children crossing the border and being sent to us from a year ago, February. We are in a crisis situation.
And these children that are coming across, you say unaccompanied.
Unaccompanied. This is a 12-year-old girl walking across the border or a coyote shoving her across the border by herself.
So they have been separated from their parents?
Their parents separated them by sending them here, or they ran away on their own up to here. They are coming here by themselves. They are unaccompanied, and then our job is to take care of them and try to find them some relative that hopefully is here in the States that we can vet and place them with that person as
And
a
in the
sponsor.
prior administration, didn't we learn that there were times where children, unaccompanied, were put with the wrong people?
Yes, yes. We, unfortunately, we try to do as good a job as we can vetting individuals, the family members and others that we place as sponsors. But yes, in the prior administration, there was one instance that became quite a cause célèbre. The Permanent Subcommittee on Investigations in the Senate held inquiries around children in, that Senator Portman was very focused on children sent to sponsors in Ohio who ended up actually with traffickers and working as essentially trafficked labor at an egg processing plant, if I remember correctly.
So is that because they were pushed out of the ORR system into the wrong hands,
Obviously,
too fast?
obviously, the screening process and vetting process on sponsors failed.
And have you changed anything to make sure that's not happening on your watch?
So we try to ensure enhanced vetting of any individual that we put children with. We have case managers that work with us and with the grantees that take on these children's cases, and we vet the individuals, we fingerprint them, we fingerprint others as necessary, for instance, other household members. We send them for FBI background checks. We do common public record checks. I think we can check the child abuse files on them. We learn immigration status on them because that can be a relevant factor. For instance, placing a child with someone who's in the middle of a removal proceeding, that wouldn't be a stable environment. So we are constantly trying to improve the quality of our vetting process to place the children in a safe environment.
And during that whole process, do these kids have the opportunity to talk to their families back in their home countries?
Oh, yes, yes. In fact,
how often?
I believe they're required to have the opportunity to speak at least twice a week. And we try to facilitate.
They have to pay for those calls?
No. We pay for that. They have unlimited access to their attorneys, and
do they get access to any kind of health care?
They get free health care, free mental health care, free vision.
How often do they get mental health services?
They are assessed for their mental health needs within 24 hours of arriving at an ORR intake facility.
Within 24 hours, they see a mental health counselor?
Yes.
And how often do they get access to health services?
They also receive that care immediately. I believe within 48 hours, they are vaccinated and receive the suite of CDC vaccinations if they do not have documentation of prior vaccination. And then we provide ongoing health care, including emergency services.
What about educational services?
We provide them with education services in all of our facilities, yep.
Have you ever gone down to one of these facilities and met with these kids?
I have indeed. I meet with the children when I'm there. I met with the student council when I was down at the Homestead
Wait a minute,
facility.
they have student councils?
They have an elected student council.
And what are the student council? Are they free to tell you good, bad, ugly, and
I begged them, tell me any complaints and concerns that you have.
What are their complaints?
Well, there were three themes. The first thing they said was, we miss our parents who sent us here. Second thing they said was, we are grateful to America. We are safe and secure for the first times in our lives. They said, it's actually heartwarming to see the gratitude on these beautiful children's faces. It was just such gratitude. And even any complaint they had, one girl wanted better sneakers. She felt so guilty saying it because she feels such gratitude to this country.
What about food?
They want pizza night. They want pizza night more often. That's the most common thing they say. They don't like our breakfast because they have to comply with the federal nutrition standards. And so they do complain about the breakfast.
So they're like other teenagers
yes.
then. Yeah.
Yes.
All right, my time's expired, Mr. Chairman, Madam Chairman. Thank you, and Mr. Secretary, thank you for being here.
Thank you very much, Mr. Weldon. Chair now recognizes the chairman of the full committee, Mr. Pallone, for 5 minutes.
Thank you, Madam Chair. I just wanted to explore, Mr. Secretary, the lessons learned from the family separation policy to see if we can figure out what went wrong. But first, let me mention an issue of documentation. I'm very frustrated with the lack of documentation on this and other issues, as you know from my previous questions. The committee sent you a letter nearly 2 months ago requesting documents relating to family separations. What few documents we have received so have been largely unresponsive. And in these cases, in these productions that we've received from you, we have received little substance, including very few communications from key HHS leaders. One weekly production, in other words, documents included almost 800 pages, but only 14 of those pages were responsive to our request. Another time, the weekly production consisted of only 7 pages of the documents. And I think it's now fair to ask, what is HHS hiding? Mr. Secretary, we've been working with HHS in good faith, but our patience has really run out. So what explains this slow production? Are there certain documents you don't want us to see? I know previously you mentioned executive privilege. Would you commit today to fully cooperate with this investigation and produce all of our requested documents related to family separations?
We are certainly working to do so. I believe we've produced over 2,800 pages of materials. We're doing it on a rolling basis.
Very little of it responds to our questions, on family separation.
I'm not personally sitting there reviewing each document that's going over, so I can't comment on that. I want to be cooperative. I want you to get the materials you need to do your job. There may be limited areas where we can't provide materials to you or have to have an appropriate accommodation discussion, but your oversight is appropriate. I share with you, I want to do the lessons learned on this. I want to learn how we can do better always.
Get back to us with the requested documents about family separation and responsive to our request. At our hearing last month on this topic, we heard from child welfare experts about the decades of research showing that family separations lead to toxic stress, result in long-term traumatic consequences. Countless other organizations have spoken out about this harm. Secretary, why was this misguided policy allowed to engulf HHS and harm both children and their families and the reputation of this critical program, if you would?
I share the concerns about child welfare, and I especially share the concerns that Commander White, who spoke to your committee, I have just the absolute highest respect and regard for Commander White. And
what's the reason why this was allowed to continue without, you agree that it wasn't good.
The President's executive order on June 22nd was able to short-circuit that right as we were in the throes of this. I focused immediately my energy on those 3 priorities I talked about, which is just ameliorating harm as quickly as possible, which was kids know where parents know where kids are, get them in contact and get them placed with reunified or placed with sponsors as quickly as possible. And then the executive order came along and all of our energies switched over. That stopped and switched over towards Judge Sabraw's order and compliance, which was a full court press to do that. So I think the timing didn't really facilitate that, but the concerns are absolutely valid around child welfare. I share them. I said at the time, nobody wants children separated from their
parents. No, I know, and I can't help, there's that quote on the wall at your headquarters from Hubert Humphrey, where he said, "The moral test of a government is how that government treats those who are in the dawn of life, the children, the twilight of life, the elderly, and the shadows of life, the sick, the needy, and the handicapped." I mean, you don't believe that this policy passed the moral test that Vice President Humphrey spoke of. I mean, you would agree, right?
I absolutely share the concern about child welfare of separating children. I can't speak to the questions of enforcing. There are significant issues, though, about exempting someone. As long as Congress has a law in the book making it a crime to cross our border, there are significant questions that this Congress has to focus on about exempting somebody from those laws simply because they have a child with them. That's a real concern.
No,
As a lawyer, it's a concern I have.
All I really want is an assurance today, because I don't know if I'm the last person. I think I might be. But can you assure us today that wholesale family separations will never happen again under your watch?
I will certainly advocate for the child welfare. There are 3 major concerns I have. One is child welfare. The second is the operational concerns that you raised about our program. The third is the reputational harm.
I just want an assurance that this kind of wholesale family separation is never going to happen again under your watch. Can you just answer that?
I am, of course, I'm not the president. I do not get to make the final judgment. I can tell you my perspective is I will always advocate for the child welfare concerns, the reputational concerns, and the operational concerns of our program.
Well, I don't think that answers the question, but whatever. Thank you, Madam Chair.
I would just take a moment to remind the witness that if someone's coming across the border as a refugee, that is a legal entry. The chair would now recognize Dr. Burgess for 5 minutes.
Thank you, and thank you, Mr. Secretary, for spending the day with us. I'm going to mostly do the talking at this point. Feel free to interject whatever you may wish. First off, Madam Chairman, I'm going to ask unanimous consent to place into the record a newspaper article from February 19th, 2019. Title of the article is Texas Republican Rejects Democrats' Criticism of the Homestead Facility for Migrant Kids. I visited the facility along with 4 of your colleagues in February. You know, this was odd because they had a press conference after the visit, but wouldn't let me participate in the press conference. So I actually called one of the reporters and provided a different perspective from what was reported, but I would like to place this article in the record. And I do feel obligated.
Without objection, the article is submitted.
I would like to I went to the Central American countries that are primarily involved in with most of the children that are coming over. And just so people understand what's going on here, a family will decide to send their child north because perhaps they have other family members who've already made the trip and they want their child to go north. I actually asked Democrats to go with me on that Codell. I couldn't get anyone to accompany me. One of the things that I learned that really concerns me is that it costs $6,000 to $10,000 for a child to make that journey. That's no small sum of money in a country that's relatively poor. When I asked the question, where do they get the money to make this journey? I was told that they borrow it from the bank. They borrow it from the bank, putting their home or their farm up as collateral. I don't know, this doesn't sound like a good system to me. Now, part of that homestead visit, I also went to the Brian Walsh Children's Village that the Democrats did not go. That's a permanent facility that's down in Florida. One of the things that struck me about the Brian Walsh Children's Village is they've got a big mural that they've drawn on the outside of one of the buildings. It's a mural of a train with children sitting on top of it. It's not like a ride at an amusement park. This is La Bestia. This is how those children get from Central America. They're brought by traffickers on the top of a train through the deserts of central Mexico and deposited at our border. They're then brought across the river. In the case of Texas, they're brought across the river by a coyote who leaves them in a small knot of people and then hopes that Customs and Border Patrol will find them before they dehydrate or burn under the Texas sun. It is not a good system that is being set up, and I cannot imagine why people wouldn't want that system to not exist anymore. Why would we continue to provide the magnet for people to want to make that dangerous journey, or worse yet, send their child on that dangerous journey? Now, Secretary Azar, during a House Judiciary Committee hearing on February 26, there was unfortunately a gross mischaracterization of the work being done at HHS to care for unaccompanied alien children. And a member on the other side of the dais on the Judiciary Committee stated that ORR created an environment of systemic sexual assaults by HHS staff on unaccompanied alien children. That close quote. So that accusation is false, and it was made without this member, to the best of my knowledge, having ever visited an ORR facility. His comments discredit the efforts by ORR employees to deal with problems, and these problems date back to a previous administration. They weren't created when Donald Trump took his hand off the Bible. So, Madam Chair, I have a letter that was written by Jonathan Hayes to this member of the Judiciary Committee, characterizing the remarks that were made and asking for an apology. And I ask unanimous consent to insert this letter into the record, and I would further ask that this committee ask Representative Deutsch to issue an apology to the men and women at ORR and HHS who work every day to see that these children are well taken care of. And I'll yield back my time. But I do ask unanimous consent.
That unanimous consent is not approved.
Is not approved?
It's not approved.
You're not going to put this letter into the record?
Sorry.
No, it's not approved. It's a letter condemning a Democratic member.
It's it is, it's a letter condemning another member. And I don't, I'm not going to, I'm not going to pursue taking the words down, but I am going to draw a line and not accept it for the record. And
Madam Chair,
let
can I
it,
appeal a ruling to the chair?
Let it remain. Well, if you want to do that, you may. But I'm not going to put those words in the record. I don't think they're fit for the record. And you've been in this chair, Mr. Burgess, and I think that were you to hear me making that request, that you would do the same thing. So,
If it's any consolation for you, they're already in the record in the Rules Committee from yesterday.
all right. Well, are you finished with your questioning?
Madam Chairwoman, if Madam
Who's,
Chairwoman,
who's asking?
me up front.
Oh, I'm sorry.
I'm terribly sorry to
sorry.
interrupt. I just, if I could, I just wanted to clarify. I think in response to Chairman Pallone when we were speaking, I made reference to approximately 2,800 documents. My staff informs me I was incorrect. It's approximately 2,080 pages. I just wanted to be clear that they've corrected me. I made a mistake in my statement there, and I wanted to be sure to get that on the record. I'm sorry about that. I apologize.
You've got good
I got a
staff
good team.
behind you, giving you,
Thank you.
the notes to make the correction. So noted, and appreciate it. Hardly anyone is left, but I still want to put out the reminder that members have 10 business days to submit their additional questions for the record. And Mr. Secretary, there were many requests, and you made several offers to provide the information that was requested. Please do that, and also respond promptly to the questions that are going to be submitted to you by members. I just want to close this hearing. It's been a long one. We thank you, Mr. Secretary. It is the budget of our nation, and the budget of our nation is a statement of our national values. And there have been those that have supported some of the things that are in the budget. You've also heard those that have spoken out where they believe doesn't meet our national values. I would just ask you to do the following, and that is to go online and tap in President Ronald Reagan's last speech as President of the United States. It is one of the most magnificent set of remarks I've ever heard. It's a love letter to immigrants. Call me after you've watched that, and I want to have a discussion with you about it. With that, the committee has concluded its business for today, and it's the end of the hearing. Thank you.